researchers. I'm a researcher. We also have other surgeons, other doctors, everybody here. So please feel free and bring something out so that everybody here can take something home. So I'll allow 3 questions now from the public. Or if anybody has anything else that wants to say, this is the time to say so that we can end this session and then continue with the next session. So, please.
So anyone who has a question, kindly show by hands. Great. Yes, there's a microphone here.
There's a mic. Yes. So 3 questions. And Reginald, Nana also has a question. So, no, let the person.
Good morning. My name is Prince. I'm from Farmers and Biases. So when the survivors were talking about their journey, I was just discussing with my colleague here that back in school, we do breast cancer awareness every year. But the knowledge that you get, even as clinicians, the knowledge that you get from that, as our midwife survivor said, isn't so in depth. Can we have a system where it's not just about the celebration, especially in the universities, but more about education? Not just sitting in the classroom to think about BRCA1 gene and all that, but understanding what it means to have breast cancer. Can we increase the awareness in the schools? Thank you.
Next.
Thank you. My name is Mavis Amankwa. I'm a women's health nurse specialist. I work in the community, in the CHIP zones, and I understand the fact that early detection saves lives. So I screen women, even at their doorsteps. When I detect cases, where to let them go is difficult. And even if I refer, they cannot afford treatment. So today I came here purposely to get people to support women in the community. Thank you very much.
Thank you so much. We'll take one quick one here before we come to Nana.
Thank you for the opportunity. My name is Kwame Eduse. I was surprised to hear that it took 3 months for somebody to get a report. I thought Ghana will have come a long way because we have a pathology services here that you can get your report in 3 working days by Pathologists Without Borders. So I want everybody to know that we want to go further than that, actually. If you can get to the whole country, the days that we're getting our reports 3 months, 2 months have passed. Thanks to this man who is talking to you now. It's a gift. I consider it as a grace. And with this, I stretch forth my arms. Tamale, I have a station there. Hopefully, we'll cover the whole country. We'll get more people to support us. And definitely, we'll make your journey better than what you have faced so far. Thank you.
Thank you. Thank you. I hear whispers of subsidy. Yes. So, Openi Kasana Ujariana and Suyasan. So I'll take yours, then I come to Nana.
Yeah. Thank you very much for the opportunity. I'll speak with 2 lenses. As somebody who practiced as a medical doctor in the rural area, specifically Nadoli and Laura Hospital in Upper West, and also now as a member of Parliament. Briefly, I share in all the presenters because practicing, I saw the cases and I witnessed the stigma. Truly, the cases I saw were at the very advanced stages. And these were cases who even went around our health facilities and you asked out, didn't you go to the health facility? You say, oh, I went. Not once, severally. But it was never picked. So the woman would keep on roaming, going back to the health facility, until it was too late. At the time of detection, you realize that not much could be done. But thank God now the advocacy is there. A lot more of our women are being enlightened. Our midwives sometimes organize breast cancer screening in the communities. And maybe now the story is better, even though we are not at the point that we desire. Now, I'm in Parliament. What can we do at that top level to change the story? We too can be advocates. Apart from pushing for resources, my colleagues are here. We can also organize some breast screening in our various communities, and also make statements and call for, those of you managing the healthcare to go beyond the stigma and come forward. It may surprise you that sometimes the issues that we discuss, the issues that are brought from the grassroots to the ministry level and brought to Parliament for attention, some of these critical areas are not there. I'm being frank. Infrastructure. I mean, those things that really are just a minute portion of our health system are what they brought. They bring. Issues of cancers. What should we do? How much should be dedicated for cancer care? You go through the whole budget, and you don't find. So it's a collective work that we all have to do, and we can play coming from the health committee that we also champion and be advocates to ensure that we work together, as a joint action for breast care. Thank you very much.
Thank you so much, Honorable Nana.
Cheme, sanefio kunita omabiage, mini ke breast cancer ba. Mini wo fio. Ke wonye wona kuni wo kwe wo ni ye jio. Nuni wo nuo jio. No ni ba ni breast cancer ba. Kuni wole ke sane wo shoda ne unjio. Nya wole ya.
Ni wants to essentially know the etiology, the cause of breast cancer.
Ago chama kenyame. Inu mwe fe shino mi to ni ke fita no eji. Breast cancer age ni okenalo. Kejigbe can be na alo age ni sani o shedani eku about yeah.
All right, thank you very much. So to summarize the questions, the first question was how to increase what to actually say in the second cycle schools so that they will know at that age when what the whole breast cancer is about. The second speaker wanted to know support from the community, which our MP, I was directing to the MPs, but they've answered it. And then Nana wanted to know the cause of breast cancer, and Nana Hima wanted to know whether there is any age where you can get breast cancer. So I think that's it. And then someone wants to know how to support the community, which also parliamentarians have answered. So, Abdul, what do you want us to tell the schools, the school children, as they are growing up? And then Dr. Dede will take what causes breast cancer and the age.
Thank you. So when my brother was asking his question, I was just nodding my head. Even as a midwife who studied midwifery, nursing, and then went to midwifery school, it's just what is breast cancer, types of breast cancer, causes of breast cancer, They run you through like that. But you see, until when you are being affected, that is when you see the real thing they call breast cancer. And so for me, I think that in our schools, everybody should be included. We should teach the practical aspects, not just the theory, the practical aspects. And the advocacy shouldn't just start from the universities, it should start from the secondary school or the JHS. Because I have met a lady who was diagnosed, I think, at age 12. Yes. And so I think we should start from the JSS. And those of us who are in medical school, pharmacy school, midwifery school, let us all get involved. Because this my friend I spoke about, Amina died out of breast cancer 2 years later. I was diagnosed. So you can imagine my fear. Anytime I close my eyes, I see Amina. Anytime I'm in my chemotherapy chair, I see Amina. And even on my mastectomy surgery bed, I was seeing Amina. Aside that, I don't know if I'll get the opportunity to speak again. Media, I'm like Oliver Twist. I want to thank doctor for that wonderful this thing, talking about the pathology without borders. These are real issues. I am not exaggerating. There's a woman in Boko right now. I think this thing is also going to 2 months. Because sometimes they have to take this thing and send it through a bus or something. And so it delays. So I'm happy there is somebody here who has taken that upon himself. And like I said, I'm Oliver Twist. To my parliamentarians, I actually didn't know we have parliamentarians here. And once we have parliamentarians here, I am pleading. I don't know even if I have to go on my knees to plead with you. Yes. We say early detection saves life. How do we detect it early? When my region, where everybody calls north, and we call it home. When Tamale Teaching Hospital doesn't have a mammogram machine, a CT scan. I actually had my first CT scan in Accra. But how many of my mothers or sisters are privileged? Some of them travel from Wa, Bolga, Binduri, Nakpanduri. They don't even know Tamale. I know there's a private mammogram machine, Habana, but you have to travel from Tamale Teaching Hospital more than 300 or 400 kilometers before you get there. These people don't know Tamale. And some of them, their husbands will even have to sell bag of maize just to give them lorry fare to come to Tamale Teaching Hospital. And so imagine they come, they have to go around, pay another lorry fare. Then they go back home without nothing. With nothing. Thank you.
I want to add to what she just said. Yes, just 10 seconds. Yes. I think with the advocacy issue that has been raised, in up north over there, we have, different activities that we do over there in terms of marriages, marriage ceremonies, festivals, and so on and so forth. So these occasions also can be used. So you can advertise, based on that occasion. Use your lenses wherever these occasions are. You can zoom it to that end. Talk to the chiefs, okay? Even if it is Auri, you get it. Go to the mosque. Talk to the local people. This is the situation that we are facing. I think it will really help.
The question on the causes, sorry. So unfortunately, we don't know a direct cause for breast cancer, but we know that there are risk factors that increase the chance of somebody having breast cancer. Unfortunately, a lot of those risk factors are things that we cannot modify. So the important ones are, one, being a woman. In our world today, yes, you can change your sex, but generally a lot of us will remain women if we are women. So once you're a woman, your risk increases. Increasing age, we can change that as well. If somebody in your family has it, we can change that. And there are a lot of other risk factors that are not modifiable. There are a few that we can work on. So we are advised to cut down on alcohol, smoking, maintain healthy weight, do exercise, eat healthy food. All those things will help, but they will not 100% prevent breast cancer. So when it comes to breast cancer, yes, we talk about the things that can help to prevent it, but more importantly, we talk about early detection. Because even if you do all the things to prevent it and you don't even have any of the risk factors, you could still develop breast cancer. So the important thing is picking it up early if it is to occur. And when you pick it up early, it's not just picking it up early and leaving it there. Picking it up early and treating it adequately. That is what would help to achieve the cure. About the age, it's more common as we get older, but it can happen at any age. So teenagers, very rarely do we see a teenager with breast cancer. I've probably seen just one or two. But as we go older, so when we get into the 20s, we'll see a few more. 30s, 40s. The older we get, the more the risk. So we tend to, when we talk about screening, trying to look for breast cancer, for instance, we say that women who are age 40 and above should have mammograms done regularly, because we know that the older you are, the more likely you are to have it. But having said that, we still advocate that even in younger women, we examine our breasts. We say we want everybody to be breast aware, to know what your normal breasts are, so that when you pick something, you can go to hospital and have it checked out. So really starting from age 20, we talk about everybody examining their breasts, going to hospital from time to time to be examined, and then from 40, having the mammograms done. Sorry, I think there was a question on whether sucking of the breast can help prevent breast cancer. All right. So breastfeeding. So if you are a mother, you've given birth to a baby and you breastfeed that baby, that is protective. That helps to reduce the chance of breast cancer. But that's protection that comes with breastfeeding doesn't translate into a man sucking the breast, because that is not breastfeeding. It's got to do with the hormones. So when you've given birth, the hormones are such that they are going to protect you if you breastfeed. But on an ordinary day, a man sucking a woman's breast is not protective, because it has nothing to do with the hormones.
All right. Yeah, that question always comes, and that's it. You can. So, and that's always women like to teach. So, in fact, time, but they are around. So you can always meet them during the break time to discuss. We wish you had the whole day, but we don't. So we have to move on to the next. Thank you very much, my panelists. Thank you so much.
Thank you so much for.
Before I hand over to Reginald, Rush is sponsoring an all year round breast cancer awareness program. So since July, we've been going around the whole country announcing it. So I will entreat all of you to leave your emails here, so that whenever we leave your WhatsApp number, and emails if you like. So whenever we are doing a radio program in any part of Ghana, you can just tune to it and listen. So it's a whole year round, from July this year to June next year. Every month we are talking about it. And thank you, Rush, for giving us that opportunity. So thank you so much. This is the end of panel 1. Reginald.
Okay, thank you so much, Dr. Nyafo. I did not want the panel discussion to end. Before we zoom into the next session, Honorable Chairman Ni, with your kind permission, I would like us to probably rise up for just 5 minutes and say hello, hi to someone. We've been sitting for a while now, That's more or less like our 5 seconds bio break. Just say hello, hi to someone. Hello, hi to someone. Okay, I think we can resume our seats now. We can resume our seats now. Thank you, thank you, thank you. Great, great. The bio break was definitely necessary. Yeah. Okay. Okay, the program continues now. Let's kindly resume our seats. Let's kindly resume our seats. Thank you, thank you. Kindly resume your seats. Please resume your seats. In 5 seconds, we continue. Great. Okay, thank you so much. For anyone who has used the Ghanaian public transport system, there's usually a phenomenon that happens. I remember my experience. First time I was traveling to Takwa, that's in the western region, and when we got to somewhere around Takrade, I bidded the driver that I wanted to use the loo, and for some strange reason, when the car stopped, almost everyone got down. So I asked myself, why? How come nobody said they wanted to use the loo? We are all suffering in silence. The interesting thing about the bio break is that at least one, we are health professionals, and two, we need to be able to move things around. But more importantly, there's always that one person who needs to ask that, you know what, can we take a 5 minutes break? We've been sitting for some time now. So it's always good. There's always that one person who prompts us to be able to do this. As we move on, we have to the second segment. We have another very fascinating video. And before that, I'd like to inform the house that there are some refreshments in the corridor. We don't want to run anybody into hypo. So if you feel that at any point you need to grab something in the walkway, there are some chops that you can just grab and nibble on as the program wears on. I also want to acknowledge the special presence of the Honorable MP for Central Tongu, Honorable Alex Hotoji. I hope I got the name correctly. And then we also have two other MPs in the persons of Honorable Isaac Ashia Odamte I think probably he's just stepped out. He's the MP for Tema East, and then Honorable Alasan Abdul Idi, the MP for Salaga North. Let's do it for him. We really have to appreciate our MPs. You know, it's an election year, and to get MPs in the room like this is not easy. They could have been anywhere, but they chose to be with us here today. We really appreciate you. We really do. Yes, we really appreciate you. On this note, we'll take the short video. This is a video which was done by the First Lady of the Republic of Ghana in the person of Madam Rebecca Ekufuado. We know her very intimately, in a sense that she has been a very critical advocate in the remit of health. More recently, she's been very instrumental when it comes to the development of the pediatric intensive care unit in Kolibu. When it comes to the various critical devices in some hospitals, she has been very instrumental through the Rebecca Foundation. Yes, we see a lot of first ladies do that, but there's a certain deliberateness when it comes to this approach. On this very high note, I want us to listen to the First Lady of the Republic of Ghana, Mrs. Or Her Excellency Mrs. Rebecca Ekufuado. Over to you, me. Our beautiful Rebecca, as our president would like to always say.
My dear sisters, mothers, and daughters of Ghana, today I'm here to talk about something related to us, breast cancer. This disease has affected so many lives in our country, and it's time we come together to fight it. We do a good job by raising awareness about breast cancer in October. But the truth is, breast cancer doesn't only happen in October. It happens every day, every week, every month, and every year. For this reason, we cannot just wait until October to talk about it. We need to be aware of breast cancer and take action every day. We need to continuously educate ourselves and our loved ones about the signs and symptoms, the risk factors, and the importance of early detection. Most importantly, we need to support those who are affected by the disease and celebrate those who have overcome it. We may all know someone who has been affected by breast cancer, a friend, a family member, or a neighbor. It's a disease that doesn't just affect one person, but entire families and communities. That is why we must join hands to raise awareness and clear up misconceptions about breast cancer. Many Ghanaian women have beaten breast cancer by seeking care, treatment, and support right here in Ghana. With early detection and proper treatment, they have overcome the disease and emerged stronger than ever before. We have good cancer treatment centers in Ghana that offer effective treatment. And our National Health Insurance Scheme covers some innovative cancer therapies that increase survival rates. So, do not sit at home in silence. Speak up and seek help from a certified healthcare professional. There's hope and support available. I'm excited to announce that the Rebecca Foundation, in partnership with the Breast Society of Ghana and Roche, has launched a campaign to raise awareness about breast cancer. Our mission is to ensure every Ghanaian woman is well informed about the disease, treatment options, and the importance of early detection. So let's join hands and fight against breast cancer. Let's educate ourselves and others. Let us support those affected and celebrate survivors. Let us make a difference in the lives of our sisters, mothers, and daughters. Together, we can create a future where breast cancer is no longer a source of fear, but a challenge we face with knowledge, resilience, and unwavering hope.
Knowledge, resilience, and the need to be resolute as a country when it comes to breast cancer. Thank you so much, our Honorable First Lady, our dearest Madam, Mrs. Rebecca Ekufuado. Our next panel discussion will be anchored by our very own senior specialist, oncologist at the Kolebu Teaching Hospital. She's in the person of Dr. Na Adoko Aite, and she will be spearheading the affairs of the next panel. Just to give an overview, the first panel had to do with the patient journey. So there's a trajectory of what we are doing today. This time around, we are going to look at the equitable distribution of resources. So we've spoken about the patient. Now we want to see practically how are resources available for the management of breast cancer. On this very note, let's kindly welcome Dr. Anna Adoko Aite. Sorry. Thank you. So just as the president of the Breast Society of Ghana, you can see she also has an avant-garde sense of fashion.
Hello, everybody. I hope you are getting your everything you are doing is worth your while. To start with, I'll call Dr. Josephine Nsafo. She's going to give us just a short talk about what equity is when it comes to breast cancer resources.
Good morning. Hello. Good morning. So I'm supposed to talk about equitable distribution of resources. So I'm just going to talk about distribution of resources for breast cancer care in Ghana. So first we're going to look at the distribution of resources for making a diagnosis. We'll talk about distribution of resources for making a diagnosis. Is that better? And we'll look at some suggested strategies for enhancing these resources, and then we'll look at treatment facilities in a similar manner. Okay. So worldwide, there isn't equitable distribution of resources looking at country to country, and within countries there isn't equitable distribution no matter how developed the country is. So here we are in Ghana, over 30 million people, and our population is not even equitably distributed. 38% of people live in Accra and Kumasi. So WHO came up with the Global Breast Cancer Initiative. Next slide, please. The pointer has given up on me. Right. So WHO has come up with Global Breast Cancer Initiative. So you see the first one is in 3 points. So their first one is to achieve diagnosis of at least 60% early breast cancer. And for that, you're going to need awareness creation. Then the next point is to achieve a diagnosis in 60 days from the time of first symptom being detected. And then the third point is to start treatment within 3 months. And they want at least 80% of patients to complete the full modalities needed to treat breast cancer. Now, the National Comprehensive Cancer Network has developed some resource stratifications which we can look at in low middle income countries. And we have basic resources, and that are essential services that you need to give a minimum standard of care. And then you can add on to it where it causes, you have resources that will cause major improvements in survival outcomes. And these resources don't cost so much. And then the next level are the enhanced resources, where it's cost intensive and does also add some level of improvement in disease outcomes. The gold standard, of course, are the NCC guidelines with evidence-based recommendations, very expensive new modern things, but the improvement in survival is not that huge. Now, the implications of having an inequitable distribution of resources is that if you don't have the full complement of diagnostic facilities at one center, and the patient has to move from here to there, it takes time. And the 60-day target that WHO has set may not be achieved. And so we don't achieve the early detection we are talking about. And then also, likewise, the treatment. You have to visit several facilities and it takes time. We may not achieve that 80%. Some will fall or give up along the way. And study done in Ghana has shown that 80% of women, if they have to travel further than 1 hour, approximately 20 kilometers, they may not bother to seek health care, not necessarily breast cancer, but generally health care. And distance has been found to be the most important factor that may influence health care. There are other factors, cost, our education, beliefs, and all that. Now, I am going to switch to a publication that looked at the availability of diagnosis services in Ghana. So for hospitals that were recognized, accredited by HEFRA and Ghana Health Service. And so this doesn't include psychiatric hospitals or orthopedic hospitals, but other registered hospitals. And it doesn't include small clinics, which are poorly resourced anyway. So they looked at 364 registered hospitals in Ghana. That's all that we have, 364. 5% of these hospitals did not consent to participate in this study. So maybe 1 or 2 hospitals you think those facilities are available may not be included here. And this survey was conducted from November 2020 to October 2021. Obviously, between 2021 and now, there may be some changes, some improvements. But for now, I'm just reporting this. So they looked at the basic resources strategy. And for that, for breast cancer, if we want to meet the NCCN basic criteria for minimum standard of care, your facility should be able to offer a clinical breast examination, excision or incision biopsy, should have pathology, should have estrogen, progesterone receptor testing, X-ray, and then a diagnostic ultrasound or mammogram. Not necessarily both, but at least a diagnostic ultrasound or hopefully mammogram. And then if you want to move to core resources, in addition, you should be able to have a core needle biopsy. Just take note, from basic to core, it's just a needle biopsy. And then if we want to get to enhanced, then you have to have all that, have punch biopsy kits, HER2 testing, CT scan, bone scan, MRI, genetic testing, and have screening in addition to diagnostic mammogram at your facility. So let's look at the facilities we have. So of all these hospitals surveyed, 33% were able to offer incision and excision biopsies, and 20% were able to offer core biopsies. And you can see that it's mostly down south. If we were to draw a red line here, it's mostly down south, more in Accra, Kumasi, spreads out a bit. The black triangles are all health facilities, hospitals, HEFRA and Ghana Health Service accredited hospitals that do not offer incision or excision biopsy or core biopsy. So likewise, 40% were offering diagnostic ultrasound, but only 6.4% have a mammogram machine on site. And we can see that in mostly Accra and Kumasi and around. So you see Atika's problem. And then on-site CT scan. These hospitals, 6% have CT scan. You see the same distribution again. And then about 40% have access to pathology services. And of these hospitals, 3% have an on-site in-hospital pathology. But the majority, 39%, are using external pathology services. So maybe the biopsy or surgery is done here and they send the pathology elsewhere. So in summary, excuse me, we find that 2 hospitals, one in Accra, one in Kumasi, account for 70% of the pathology services in this country. Only 1 hospital in the northern half of the country has an in-hospital pathology service. 21 hospitals have diagnostic mammogram machines, and these are all located between Accra to Kumasi. The upper part of the country don't have any. 7 hospitals have MRI. Only 1 hospital in Ghana performs bone scans on site. And no hospital at that time was offering on-site genetic. So when we look at so we find that there are 13 hospitals. That is 4% of these registered hospitals that meet the basic criteria as defined by the NCCN. And this will serve 30% of the population that live within 20 kilometers of one of these hospitals. That means the rest are beyond 20 kilometers. And out of these 13, 11 of them meet the core criteria, which is good. But no hospital at the time of this study met the enhanced criteria. And this was because you have to offer both bone scan and genetic testing on site. And that was in 2021. But I have to say that 5% of the hospitals in Ghana are not included here. Also have to say that there are a lot of private facilities, especially around the hospitals and elsewhere in the country. And we are not reporting diagnostic centers, not hospitals, diagnostic centers. So you may get a private mammogram. I think Antika mentioned there was one somewhere in the north. But these are registered hospitals. We are not looking at diagnostic centers, just to clarify. And these diagnostic centers obviously will add to available services in Ghana. So they are offering a very essential service. Now this publication I looked at after doing a survey and seeing the available facilities. they were able to identify these hospitals. So you look at the list of 12 hospitals here and the services that they already have. That's on the left, the services that they already have: clinical, breast examination, pathology, excision, all that. Now, if you want to upgrade them to basic criteria, all you have to do is add one or two things. So for hospital number 5, for instance, if you add ERPR testing and X-ray, they qualify. For hospital number 10, if you just add ERPR testing, they qualify, and so forth. So they are suggesting a plan that these hospitals, they're already there, they are doing well, they almost have everything, with the addition of just 1 or 2 extra things. Hospital number 12, if you give them pathology services, not necessarily on site, but you give them access to pathology services and the diagnostic, they may have screening, but diagnostic ultrasound, you've already raised them to a basic criteria. And if we were to do this plan, for instance, it's a suggestion that they proposed. You see this map here on the left, there are the few 13 hospitals. Now we have new 12 hospitals added to that. So we've increased the number of hospitals, and it serves an extra 6.6% of the population within the distance of 20 kilometers. And just a reminder, all we have to add to these basic criteria hospitals is a core biopsy, and they've reached the level of core, the level of the core criteria. So moving on, let's now look at treatment centers. So another series in the same publication. This one was headed by Schoenhaus. The first one was by Dr. Price. So looking at the same number of hospitals. Also, they categorize the treatment resources you need to the basic, the core, and the enhanced. So to have basic minimum standard of care to treat breast cancer, you should be able to do surgery with axillary lymph node dissection. You should be able to do a total mastectomy, and you should have tamoxifen available. So if you want to move to the core, you should have all that. In addition, breast conserving surgery, sentinel lymph node biopsy, aromatase inhibitor, arimidex, that's another type of hormonal chemotherapy, and you should have radiation therapy. And then if you want to move on to enhanced services, you should be able to do breast reconstruction and have HER2 testing available. So a look at the treatment services available in Ghana. Right. So we have surgery all over, and you see that mastectomy, you have 50 hospitals that offer mastectomy, but it's spread in 12 out of 16 regions. Now let's have a look at axillary lymph node dissection, which is so important to offer basic standard of care. And you have 33 hospitals that offer this, and that's a spread across 9 out of 16 regions. So there's surgery, but for the critical axillary lymph node dissection, 9 out of 16. Then you have hormonal therapy in at most 8 regions, and different types of hormonal therapy available. Then also we have chemotherapy available, different drugs in a maximum of 8 regions. So the other 16 regions don't offer chemotherapy services. And also trastuzumab, a drug that we use, is available in 4 regions. And radiation therapy, you know, we have 3 centers and it's located in 2 regions in Ghana. So we find that 40 hospitals offered at least one of these treatment services. And most of these hospitals were in the Greater Accra and Ashanti region. And these cancer services were not available in Ahafo, Bono East, Oti, Savannah, and the Western North regions. When it comes to breast cancer surgery, I mentioned, yes, axillary lymph node dissection at 33 hospitals, that's in 9 regions, and were not available in these other regions. But there were 45 other hospitals that were able to offer mastectomy, but we didn't classify them as basic surgery because of the absence of axillary lymph node dissection. Systemic therapy also is available, and 15 hospitals offered tamoxifen, and so forth and so on. Targeted therapy we mentioned is in 6 hospitals. Radiation therapy, we know 3 hospitals in 2 regions. Now we should also look at the human resource, available human resource across the country. So we have surgeons in all, at that time, they documented surgeons in all the regions with the exception of the Savannah region. There's anesthesia, oncologists. There were 8 hospitals at that time that had oncologists, and these were located in 4 regions. We have plastic surgeons in 7 regions, general practitioners all over the country in all regions. Now, looking at these resources we've mentioned, back to the NCCN criteria. So you see there are 9 hospitals which meet the basic criteria, and they have all these additional services. So they have more than what it takes to basic, but they don't quite qualify for core because they are missing 1 or 2 things. And the enhanced services were in 2 hospitals. So once again, they proposed that if you look at the 9 hospitals that are already at the basic level, there are 12 hospitals they selected. If you add on 1 or 2 missing services, now we'll have a total of 21 hospitals and would have increased the number of regions covered from 5 to 10 and so forth. So that plan, you realize that the new 12 hospitals they've selected, if you were to give them 8 of these hospitals, if you were to make tamoxifen alone available there, 1 drug available there, you've increased their status to a basic criteria hospital. There were 2 hospitals, if you could offer axillary dissection, you've also improved them and they meet the standard and so forth. And this will bring on 5 new regions to which now we have extended basic breast cancer services. And this hopefully should bring 66% of the population within 75 kilometers and 36% of the population within 25 kilometers of the basic standard. So they also recommend that we can also push 1 hospital to the core level and then another hospital to the enhanced level. So it was an idea just to work with what we already have, because obviously we already have a lot going on. An addition and strengthening of the existing facilities can just raise it to meet the next level of care. So with that, so with that, we are here to discuss the way forward. And perhaps, I would say not achieving equitable distribution, but we can certainly improve equitable distribution by targeting these hospitals and expanding the available services. Obviously, there are challenges. Obviously, costs for diagnostic and treatment equipment. Then we have inadequate numbers and distribution of health personnel. We all want to stay in Accra and Kumasi, especially me. And there are also inadequate distribution already of the inadequate facilities and hospitals, and the distance from the existing facilities is also a major concern. So we are here, we are all national stakeholders, we can start the discussion. I think one or two things that I may suggest is the periodic, we need national guidelines which are periodically updated. And you see, we have general practitioners and surgeons everywhere across. So if we are updating ourselves, CPDs and guidelines, we should be able to improve the care we give out. There's an urgent need for training of more specialists, all grade of specialists. You see, oncologists are only in 4 regions. We need to acquire equipment, radiotherapy machine, the whole country 3 in 2 regions. Mammograms, we've heard a lot about that. And then also we need to improve and shorten the existing referral pathways to cut down the number of facilities that you need to visit to get a complete diagnosis, so that we can get that in the 60 days. To cut down the number of facilities we need to visit, so that we can get all the various modalities of treatment, so that at least 80% of us will complete breast cancer and be saved. There are more ideas that you have, and that is why we are here. Thank you for your attention.
Thank you very much, Dr. Nsafo. When Dr. Nsafo was talking, the thing that kept ringing in my head was, hey, Accra is not Ghana. It's very easy to look at Accra and think that things are all okay. But I think right from the start, Attica made us aware of the fact that we are all in Ghana, but we are all not the same. And recently I came across this picture that has been quite significant for me. And that's what we've shown on the screen right now. As a race, or as human beings, our reality is that there are people who are all the way up there. They can afford anything. It doesn't matter where the thing is available at. They can travel to go and get all the treatment that they need. And then there are a few people who can get by, you know. I mean, they'll do like the Ghanaian said, back, and they'll be able to do something for themselves. But there are people who are right below us, who don't have the same things that we have and don't have equal access. And if we plan to make life better for every Ghanaian, then we must not look at just equality. And as you can see from the picture, equality is sharing the tables so that everybody can stand on. But some people are already high. So in fact, what we should be looking at is equity, where those who are so deprived would be given extra help. And then maybe, just maybe one day, we'll get to the point where we have justice and everybody will have a level playing ground. To help us do the discussion on equitable distribution of resources, I'd like to call my teacher. He's the past chairman for Council for Breast Society of Ghana, Prof. Clegg Lamte. He's a consultant surgeon as well. And we have a representative from the Ministry of Health, Mrs. Susan Malik. Please join us at the front. And then finally, I think it's fair to call one of our members of parliament to join us, because whatever we do, they are the ones who help push our agenda. So I would be happy if one of you would like to join us for this discussion. My very first question would be to ask you, So my very first question will be to everybody on the panel, just to tell us what you think about when you hear equity of resources.
Yeah, thank you very much. Rightly, you've given us a good example about equity, where we realize that practically in Ghana, we don't have that playing field where resources are distributed according to the needs of patients, of regions, of districts, and of communities. So that is a reality, and the data and the evidence from the presentation and the survey that was done has clearly demonstrated that we don't have that equitable distribution of resources in this country, and that from our angle as members of parliament, as government, it calls for urgent action and the need to really address the issue of problem of equity in the country. That's what I can say.
Okay, good morning. I want to make a little correction. I'm not from MOH. Pardon my voice. I'm from Modloco Breast Cancer Foundation. And the minister I am representing. I'm not representing the ministry. He's supposed to be here, but we all know he's a cabinet minister. And at any time, he'll be called to attend to issues at the presidency. Equity, as is being asked, obviously everything must be on a good scale that even the poor and the rich can benefit from it. But this is where we find ourselves. It doesn't really seem like it. And it's our hope from the stats that Dr. Insafo just presented. It means we have a long way to reach equity. We haven't gotten there at all.
Right, thank you. I don't think there's too much to add. So it's basically to make sure that everybody who needs help, thank you, Nee, gets the help. Sometimes that means reducing what somebody else gets so that others will also get. But where you have a situation where one person is getting everything and you have a limited amount of cake to share, then obviously others wouldn't get it. I mean, there are pros and cons of the arguments. We will not go into that, but that's what comes to mind.
And my is, can we achieve some form of equity? When we look at the way our system is right now, do we think, and how can we achieve that?
Yes, we can. And it's about priorities. For instance, if we take the issue of breast cancer and the resources that we need to provide, quality, care for these clients, I believe that as government, as a society, if we prioritize the issue of breast care, we'll get the resources. If we don't prioritize breast care, then the resources will be shifted to a different area. And now, like Prof said, the scanty resources available is what will be left for breast cancer care. And then those who can fight for the little would get it. Others will be denied. So it's about prioritization. Let me just put it that way. That look, as a country, we might not have all the resources we need, but we have some resources that if we prioritize our needs and we distribute these resources, we'll be able to make some impact, especially in the area of breast cancer care. Thank you.
Can we achieve equity? I don't know whether we can achieve it 100%. We certainly should aim for it, but I certainly think there's a lot we can do, even from the suggestions that the survey suggested. I think they were practical. Already we have some resources available. Just core biopsy, for instance, we could do something practical, hands-on. Maybe it's not something that only surgeons should be able to do. So the general practitioners everywhere, we can train them to add this one on. Then they're able to diagnose, and then they can refer. So I think there will be some practical ways in which we can improve. Using the word achieving, I'm not convinced. I realize that even in the US, there are inequities, even within one state. But I certainly think that we can do a whole lot better.
Well, I also think it will take a long time to bridge that gap, because I will speak as a survivor as well. There are some, I know there are doctors on the panel. There are some facilities you visit as a patient, and your appearance tells the doctor what should be prescribed to you. And that's the honest truth. Because they look at you, they look at your hairstyle, your outfit, and they feel when they prescribe such medication to you, originally and realistically, it's so expensive, they wouldn't like to burden you. So then they will not even prescribe it to you. Meanwhile, that medication is a key component of what will bring you to your survival journey's end, or however. So getting it balanced, I don't know when we'll get there. I really don't know. And for us, or for me, I took my journey through Kolebu. I don't know about other facilities, whether there is some kind of surveillance, monitoring, when how patients are being handled by practitioners, because all those things come together to bring that kind of level ground for the rich and the poor. And honestly, I am talking from experience. A young doctor looked at me and said, "Uoska," because on the day I was going, I dressed casual. So when this I metro lab non keti. And that's a very serious situation. It's a very serious situation. I'm talking about realities. So bridging that gap goes beyond what government can do, goes beyond what doctors can do, goes beyond what even patients can do. It's a collective game. We all need to put our energies in, play it well, so that we can have a headway.
Susan, may I just make a quick comment on that? You know, it's very dicey when you are on the ground. So I have a patient and I requested that she should go and do a CT scan of chest and abdomen. I mean, mine is to treat you. That's the gold standard. So I wrote it. Apparently, this may cost so much. I don't know the cost. Mine is just to write it. And then she comes for review in 3 months. And I said, "Oh, are you now coming?" She said, "Yes. You told me to do CT scan. And it's taking me 3 months to get that money." And I was like, "Oh, madam, if you had told me that you couldn't afford it, you went to check the price and you came back, I would have written chest x-ray and abdominal ultrasound. And it's just going to cost a few hundred cedis." You see, so it's very tricky. So sometimes we will ask the patient. I think after that case, sometimes I say, "I want to write the best investigation. It's going to cost more than this." If you genuinely feel you can't afford it, then I'll write the cheaper one for you. What do you want? Those days that Herceptin wasn't on health insurance, you tell a patient that you qualify for this amazing new drug. It will cost you 6 or 7,000 cedis every 3 weeks for 1 year. And then the patient is depressed because she feels that she's not getting a medication that will save her life. Then I wish I hadn't told her. Thank goodness now it's totally covered by health insurance. But it can be tricky for a clinician. You see, should I prescribe gold standard for everybody? Should I also ask you first that can you afford this? In tree, that is Mami Uwosika. You see, so I'm not covering up for any doctor. But somebody said, I didn't do mastectomy because the breast, I didn't like the way the doctor said, I have to remove your breast. What should I say? I should tell you we are going to remove your breast without saying we are going to remove your breast. So it can also be very difficult for us. You see, our cultures are different. What every patient can handle is different. There are some very confident women. Look, doctor, give it to me as it is. I want to know this, I want to know that. And I'm trying to be polite and they are laughing. Why you say it? Tell me. Everybody is different. And some people too, they don't want to hear details. Doctor, they don't tell me anything. Just do whatever you think is good. So we are also in a bit of a bind. And equity is not a simple thing. You have to consider all these things.
Right, thank you. I'll support Dr. Ansafo when she said that we cannot completely achieve it. I don't see it that we can achieve it, but we can work towards it. And I think we are all together trying to work towards it. The example she gave about Herceptin is a very good example. So this was a drug which very few people could afford. And even of those who could afford, they could afford like a certain dose which was not there because it was too expensive. But then government comes in and now everybody who needs it can have it. So parliamentarian is here. So government has a lot to do in achieving equity. So we hope that the government will take this up. And sometimes equity in resources, that's human resource and then equipment and so on. Sometimes if they are not guided, then you have a mismatch because government can say, okay, we want to bring resources all over. So there's a hospital sitting somewhere without the specialists and so on to use it, and then they go and put equipment there. Meanwhile, the equipment is needed in another place. So there has to be a matching of these if we are to achieve or to attempt to achieve everything.
Thank you very much. So I just want to say that pharma has been very instrumental in the management of breast cancer, and we want to say a big thank you to all of you. But we also want to say, like Attica, I can also ask for more. There's so much more that you can do to help us. And so when we come knocking on your doors, please don't close the door on us. There's so much that we need to do to make sure that every patient who's diagnosed with breast cancer can have a good outlook. You know, we understand that it's a disease that can have such a varied outcome. And sometimes the very nature of the disease might mean that the outcomes may not be good. But when you tell a patient that you've been diagnosed with this disease and whatever is available to make sure you would survive is available, just that alone is enough to encourage the patient to do all that is required so that they can achieve the best outcomes. And so our plea this afternoon, I think we are in the afternoon already, is that there's a lot that we can do by ourselves. And over the years, we've realized that we don't even have to be everywhere in person. If there's anything that COVID taught us, it's that you can be sitting in Accra and be holding a meeting in Tamale. If it's by telemedicine, however it's possible, we can actually even have pathology slides reviewed online. So there's a lot that we can do, and we think that probably as Breast Society of Ghana, we should involve Parliament. We should go to them with what we think can be done. And there are a few things Dr. Nsafu showed. Just making tamoxifen available can change the nature of a facility to a basic one. And honestly, it's difficult to have patients travel from the north to come to Accra to come and have radiotherapy. It's difficult. And it's about time that as a country we start looking at cancer care and breast cancer in particular with a new lens. Other countries have done it. These days, if you go to Egypt, you'll be surprised. Everybody diagnosed with breast cancer will be managed in a facility that is well equipped. And it's only because somebody thought about it. You know, sometimes I don't know if I should pray that some big people should get cancer. I'm not sure. Sometimes I feel like that's the only way they will understand what is happening. And if you look at the picture we showed, they are probably high up there, so they go elsewhere. But if COVID taught us anything, is that there might be a time when you. Thank you very much. I don't know if anybody has any comments, yes, in the audience.
Yeah, I was going to speak at the first time, but I couldn't get the opportunity. I was there when the medical superintendent of my district hospital approached me for an air condition, and I bought it for them. Then another time he called me for some bundles of iron sheet. I bought it for them. Then just last week, he approached me that in October they want to have a cancer screening exercise. And he said he couldn't understand why cancer, they are diagnosing a lot of cancer in my constituency. And they wanted to have some kind of screening again. I said, oh, I'm tired. This one, I cannot help you. But having come here, having listened to the stories, this one is a pledge. If you can hear me now, I'm going to fight for money to support them to get that done. You know, all these things about perception, when they talk about cancer, like when he told me the case is that they've diagnosed some people, I think those people are condemned. That was the thinking. Because the moment they mention cancer, they don't attach life to it at all. We don't know. So there is the need for us to do a lot of public education about some of these things. As a member of parliament, I don't know much that people can survive. Because we are here, even if they tell me I have cancer, I think that's the end. So that perception must be removed. And we need to do a lot of public education. Fortunately, we are going to start our campaign soon. I will take it upon myself, and I know my colleague will all do it. We'll begin to tell the people in the villages that go and check. Because with early detection, you can be treated. They don't know in the villages. So that we'll start from there, small. And I will encourage. I have realized that there is the need for male involvement in breast cancer management. Having listened to the Tamale woman, she would have died if the husband had thought that, oh, I'm married to two, and with cancer you cannot survive. So the husband would just forget about her. She would have died. But fortunately, the husband was very supportive. So the first support system should be the husband. So, you know, what we were doing initially when they were talking about contraceptive use and others, without male involvement, it was dangling because women had to hide to go and assess it. But when WHO came out that, oh, there should be male involvement, I mean, we are getting a resource. So I want to suggest that with this cancer treatment, the male must be involved. The male must be told that your wife can still come back to you alive. So you must be supportive of your wife. Thank you so much.
Thank you very much. We have a few more.
Yes. Thank you very much. My name is Susan Yemedi and I'm a survivor. And I'm very glad that we are having this conversation. This is my first time in this forum, so I'm very grateful for the opportunity. I think that Breast Society of Ghana has a very strategic opportunity today to look at how best we can engage the stakeholders. Parliament is well represented. And I want to reiterate the fact that our parliamentarian honorable said that the resources are very small. And so those who fight hard are the ones who get their attention. So I would like to suggest that Breast Society of Ghana perhaps look at a plan, an advocacy plan that is strategically directed at key stakeholders. The research that Dr. Josephine Nsafo talked about gives us a lot of data, and that's what they need, evidence to support their argument when they are dividing the cake. We have to be there before budget is read. We should be there when budget is being prepared. And so for me, I think that if there's something that we can do, one, like Dr. Akwesi said, maybe he's requesting the mammogram for Tamale. Perhaps collectively as a society, we can request maybe 3 key things that the health committee can champion for us for next year. So that before budget is written down and they cut the cake, our needs are on the table. And when it is being read, we can hear our pieces in there. So that is my suggestion for today. Thank you.
Thank you very much. My name is Emmanuel Nhunado. I'm the founder of Naomi McCaffrey Breast Cancer Foundation. Naomi happened to be my wife. I was proud when Honorable was talking about the fact that men should get involved in the advocacy. I established a foundation in memory of my late wife. My wife was diagnosed of stage 3. She died this year, 25th of May, in our room. And I've met most of the doctors that were attending to my wife at Kolebu. Dr. Yebila, she was around. She can attest the fact that what we went through at Kolebu when she was diagnosed wasn't easy. So after her demise, most people asked me that, why are you not resting after burying your wife on 13th of July? Just rest and allow yourself to go through the healing process. I was like, no, I can't sit down and allow other innocent people or allow other innocent ladies to also die. So I took it upon myself to establish a foundation, which is Naomi McCaffrey Breast Cancer Foundation. We'll be having our first conference in the school that she completed, her alma mater, Presbyterian Women's College for Education, on the 26th of October, where we are expecting to have about 1,000 students. We've stretched our arms to, the first panel was talking about starting the education from the basics. And we've stretched our arms to invite all the secondary schools in Ebri Girls, Adontain, Ebri Sectec, Kitase Basic School, some other churches in Ebri, and some other schools in Dowenya Town where she did her internship as well. So that is what we've taken up upon ourselves to do this conference, to create more of the awareness, because believe you me, when she was in school, we heard about the breast cancer, but we didn't take it that serious. And if it hasn't hit you, or if you've not been in that situation before, you wouldn't know or you wouldn't understand how it is. So when I hear people tell me that, my brother, rest, you just buried your wife, I'll be like, no, you don't understand. Because there'll be a time I have to drive my wife from Tema to Kolebu. If I don't get a means of using an ambulance, I have to use our car with the honk on it. And it hurts me so much that I can't sit down and allow innocent people to go through. So this is a humble plea. I already have some of the stakeholders here on board. It's my humble plea that BSoG will come on board with me, plus all other stakeholders here. Unofficially, I'm inviting you all on 26th to our maiden conference. Thank you.
Thank you so much, Dr. Nadokaite, for moderating this session. At the heart of all the discussion we are having today is kudi, money, resources. We can speak all the English, but if the resources are not available, they will only be pipe dreams. So we are really grateful for the insights that were shared by the various panelists. Media team, on your mark, would like to take the next video before we do the last panel discussion, which will be centered more importantly on financing breast cancer treatment.
Breasts, but I was afraid to visit the hospital. So it took me 3 months before I visited the Tamale Teaching Hospital. Then I had a biopsy done, and CT. I had a scan, and in August I was diagnosed. I reported to the hospital somewhere April, and in April I had a scan done, and after the scan said the lump was suspicious, so I had to go for a biopsy. And so the biopsy, the hospital sent it to Accra, because Tamale Teaching Hospital doesn't have a biopsy or pathology with that body, so they had to send it to Accra. The results took like 2 weeks before it came. When it came, I had to do, they said they were not sure. It was normal breast tissues. So I had to take another second biopsy. So I had like 3 biopsies, and one of the biopsies had to take almost 6 weeks before I had the results. So imagine I visiting the hospital in April, and then I got diagnosed in August, because the hospital doesn't have a CT scan as at the time I was diagnosed. But then I could have at that time, once my oncologists were not sure, I could have had a CT scan, but I never had any as at that time. So those were the challenges with my diagnosis. This journey, yes, it affected my work, because for 2 years I was not able to go to work. I had to go for regular visits. When you take chemotherapy, it comes with a lot of side effects, and some of the side effects are nausea, vomiting, diarrhea, and so I was weak most of the time. So for 2 weeks I've been home visiting the hospital all the time. So I've not been able to go to work or to do my regular activities. And in terms of taking care of my family, in fact, even up to now, I still feel the impact, because I didn't get that family support, people to take care of my children. At a point, I had to travel to Kolebu for surgery. I have 2 kids actually, so I left the children with my husband, who is also working.
We had to leave. I have a foster daughter who is like 13 years old, and today, as I speak, because I was not around to train that child, I was in Kolobi for 6 months. By the time I came, this girl started seeing men, and until now, I am still facing that challenge. So it's not an easy journey. I've not been able to give my children that kind of motherly training for almost 2 years. Be with them, that kind of motherly love. So the journey is really a very big challenge. So when it comes to breast cancer treatment in Ghana, we all know that there are gaps, and the gap in northern region is so challenging because Tamale Teaching Hospital is the only hospital that serves the Upper West region, the Oti region, Upper East, Savannah region. And during my journey, I have met women who travel all the way from Wa, Bolgatanga, Ketakrachi, Salaga, Damango to come for simple chemotherapy. And those women will have to pay for transportation to come for chemotherapy. Some of them, there is no sleeping place for them when they come around. They have to sleep at the OPD of Tamale Teaching Hospital, which is a challenge. And some of them, because of this, when they go home, they don't even want to come back for treatment. Tamale Teaching Hospital, as at the time I was diagnosed, till now doesn't have a mammogram machine. And a mammogram machine is one of the devices that every woman or man who has been, before you are being diagnosed, you will need it, depending on your age, to confirm your diagnosis. As a breast cancer survivor, I never had the opportunity to get a mammogram machine, the mammogram test done. So I had to travel. It was when I traveled to Accra that I had my first mammogram test done. Women who, when I met during my journey, women who needed mammogram test had to travel all the way to Konfanochi, Kumasi. Look at the transportation cost from Tamale to Kumasi just to have a test as simple, a test that will take like 5 minutes, as simple as a mammogram test. And this woman end up dying. There is no CT. Tamale Teaching Hospital doesn't have a CT scan that we have to take. It took me to, I had to travel to Accra before I had a CT scan done. Or when our doctors usually think we are supposed to have a CT scan, we have to go outside, and outside we have to pay. And you have a woman traveling from a village under Salaga or Boragatanga who has never been to Tamale before, going around, walking around Tamale to ask where she can have a CT scan done. It is so challenging, so challenging. We don't have a radiotherapy center in Tamale. The whole northern region, there is no radiotherapy center. We have to travel. When you need it, you have to travel to Kumasi or Accra. And I think we are pleading that northern region, we are part of Ghana, and breast cancer should be taken seriously, because in my journey, like most of my colleagues I used to go for treatment with, over 10 died, if I am going to count, because of some of these simple things. And so I am pleading with philanthropists, NGOs, the government to come to our aid, especially the mammogram machine, because the first thing you need to be diagnosed before you even go to, for your treatment. So I'm pleading with anybody that can help us to come to our aid, to help us to get a mammogram machine, radiotherapy center, CT scan machine, chemotherapy drugs, and then we need some financial support. Most of my mothers, my sisters, I'm one person that was fortunate to get financial support from friends and family, from my workplace. But what about my mothers, my sisters who never had this? They died. And must a woman die because of lack of finance? No. We know that the health insurance covers breast cancer treatment, but it's not everything. I had to pay for almost all my chemotherapy drugs, surgery. So I'm pleading with anybody that can help us, the northern region. We are going through a lot of challenges when it comes to breast cancer treatment.
The northern region is indeed going through a lot when it comes to cancer management. Attica epitomizes everything that is wrong with the current system we are running. And this is a gentle reminder to all duty bearers here in seated that there is a lot of work to be done. Usually in the education system, teachers have this expression they use: more room for improvement. More room for improvement. So this is a wake-up call to all of us. There's a lot that needs to change if we want our fellow citizens to have a dignified treatment within the healthcare space. At this point, we'll invite Dr. Grace Bachman, who is the Medical Director of Sonotech. She's also a public health resident with the Ghana College of Physicians and Surgeons, and she would be anchoring the financing breast cancer treatment panel session. Your audience, you have your moderator. Thank you.
Thank you very much, Reginald. Like most of us, I've sat through the morning session with mixed feelings. On the other hand, on one hand, I'm excited. Excited because Breast Society of Ghana has given us this wonderful platform to talk about some of these very, very critical issues. But on the other hand, I'm quite sad and emotional because this morning has reflected that there's still a long way to go. We've come very far, but there's still a lot we can all do. When you listen to the first panel and the second panel, there's one thing that runs through: financing breast cancer treatment. After all the talk, making noise, people should get in their diagnosed. Now it gets to treatment. People don't have money to finance most of the things, and day-to-day patients, well, I don't run away because there was no money. And really, that's what we're saying. They come to you, listen to you, write a lot of things for them to go, and then we lose them. Financing is something critical we are going to discuss this afternoon. Our national health insurance scheme is doing very well. I think it's one of the greatest things the government has done. Breast cancer is one of the few is covered. But the realities on the ground. Patients still have to pay huge amounts out of pocket. And for some families, it's almost like a health which wipes away, the whole savings and expenditure. It's a big deal, and that's what we're going to talk about this particular afternoon. So before we go on to the panel, we would have one woman I admire so much to give us a short presentation. When I was in medical school, we have a short rotation through her place in Kolebu. And I remember those times, all the things that she said, I didn't understand. I didn't understand. I agree with someone who spoke earlier on that in medical school, they should let us appreciate some of these things very well. When we come to oncology, the things you say. Okay, so ladies and gentlemen, help me welcome a consultant clinical oncologist at the Kolebu Teaching Hospital, Professor Verna van der Poel. A round of applause for her, please.
Thank you so much. Unlike my other colleagues, I can't read from my phone, so I'm going to stand on the side. So I'm going to talk about funding of breast cancer. Next slide, please. That was me. It's not moving on. Hey. How am I going to read my slide? Okay, so this is just talking about so this is just to say what everybody else has said, talking about the patient's journey as the oncologist or the public health physician who said, that you have patient interval, the patient goes through screening, symptoms, and then they go to the clinic, and then we are supposed to do this within 60 days. Somebody has already told us that. Then we'll go through diagnosis, which includes so many things. I don't have to repeat them. Imaging, biopsy, clinic tissue sampling, pathology, all of that before you get your diagnosis. And a lot of things can happen during that period. Then you go for treatment. The treatment, unfortunately, depends on the type of breast cancer you have and also the stage of the breast cancer. So that has to be accurately determined. And then you go for your treatment, surgery, radiotherapy, chemotherapy, and then support services. So it's a very long journey, and unfortunately, it's all very busy and expensive. So a picture is worth 1,000 words. That's one of my teachers told me. So you say it nicely. The first slide was so easy. But this is actually the report of a patient. You can see it's much busier than what we envision. Okay, the things they go through, pre-diagnosis, this is a patient actually chatting this, and it tells you what they have to go to and the path. And this is not an easy thing to do. I went for a meeting in Hogwe about a breast cancer research project, and I told myself, if I lived here, I am not going to Accra for treatment. Because I just saw what the patients go through in terms of the traveling. There's only one caveat, under which I'll come to Accra, is that my treatment is free. So that is the big gap that we have in determining that our patients will get the full treatment. Okay, so this is again to tell you that the different types of breast cancer. This is a maze. I don't want you to read it. I'm just telling you the things that go into diagnosing a breast cancer. No breast cancer is the same. They are different. And this has to be accurately determined. And I have to say here that some of the treatments, even though we have a lot in Ghana, but then there are gaps. Like in terms of the pathology, I'm glad some of the pathologies are there. There's a fish test, which is very important, but there's none locally available. And I think it's a huge gap that needs to be bridged. It helps with the diagnosis of breast cancer and those who have to go on a particular treatment. So we are getting there, but we are not quite there. So I think a lot has to be done with this. So this is a maze. And as you can see, a lot has to go into the treatment. Dr. Nsafo talked about the pathologist, the oncologist, the surgeon. All this have to sit together to decide which is the. So one person cannot just sit in an office and decide. We have to follow guidelines to decide which is the best way for the best outcomes of the patient. Unfortunately, they are not cheap. It's a bad habit, I guess. So this is just to say the influences that make somebody want to go for treatment. It is based on the social ecological model. The first thing is the interpersonal relationship. Financing barriers is number one as to when a patient will decide to come for treatment or not. So we have to remember that. Then you have other factors about treatment and beliefs about outcome. Believe me, I'm a professor, but if I have breast cancer, I might go to the herbalist. It's in our DNA. It's something we have to remember. Okay, so it's not unusual. Don't blame anybody from going through that. When you have the diagnosis, it's a totally different story. You can say all you want. So that's one thing you have to, the things that make, like she said, the patient came and didn't say a word because a lot of things are going through her mind. And so we need to respect the patient's point of view when it comes to me. You have to, sometimes we just misunderstand, just like how our parliamentarian told us. You misunderstand the whole concept of cancer. I went to a party once and one of my colleagues, my friends told me, oh, all your patients die because you're oncologist. And I said, who told you that? You don't know the number of patients at this party with me. I can't point them out to you. Some of them are 5-10 years because they don't come out and say it. It doesn't mean that people die from their cancer. In fact, and I tell my patients, there's no guarantee that next time when you come, I'll be here. Okay, so for somebody told somebody that in the next 2 years, we don't know whether they'll be alive. Tell the doctor that they might not be alive either. And we saw that from COVID, that we lost most of our caregivers. So I think nobody has the right to tell you that. Okay. All right, so these are just the things that we know, signs, symptoms. Then the next is interpersonal. Not just you. Now your spouse, your friend, your partner, that's the new word. Your partner also decides how the treatment will be. Your family prioritization, maybe your kids are in school, you have to pay school fees. You live in Hawkway or Kitikrachi, you have to cross the plantoon to come to Accra. All these are factors that decide whether you come for your treatment or not. And then the support systems. Is anybody going to pay for your journey into the cities or even to the next CHIPS compound or the next hospital to get your treatment? These are the support systems that might affect how you take up your treatment. Then the community, we should never forget the community. So the community has to support our patients to decide whether they can come for treatment or give them the positive vibes. As we've all heard, you can survive from your cancer. That's the first message that everybody needs to. It's difficult, it's a long journey, but you overcome it like everybody else. And that's where we need the survivors to come in. And thirdly, also, the community will tell them, there's health insurance that will cover your treatment. So go for your treatment. We are all doing this just in the teaching hospitals at the government level. We are forgetting the community. But the community has to have a positive vibe to make sure that this patient is going to be covered in terms of their finances. That is the only way they can give that positive, a reinforcement to the patient. So that is also missing a bit. Most people don't even know that cancer can be cured, and now we know. Now most people don't even know that cancer treatment is covered. People don't even know that, but now we know that. And these are the messages that have to go out into the community. Then also the beliefs. So if somebody's brother's cousins died from breast cancer and went to the herbalist, times I've been cured by breast cancer because I went to the herbalist or I prayed about it. But faith without works is barren. We all know that. And I think that's a big, a missing gap as well. All right. So our community's messages can change. That you have cancer, and so what? The next thing is for treatment. And there's no other way. It's like a broken leg. You have to fix it. The herbalists fix broken legs. It's the same thing. You have breast cancer and it has to be fixed. And I always say it has manifested physically. And there's a spiritual cause. That's what you want to believe, and that's fine. But you have to take care of both. So you need to come to the hospital and pray that your treatment will be given. Then you have the organization overall. Healthcare personnel, the accessibility to care, resources, what is available to you, and all that is in the broad shadow of what you do. In terms of the community yourself, what has the organization or the facilities have to do to support you? Then you have policy that is from the top, from the government. How your treatment is going to be covered in terms of national health. So the efficacy of the national health insurance is the overall broad umbrella of what will come out of your treatments. And then integration into the society, into the community and into the rural regions is what will determine how you will have your treatment also. So financing is number one. Basically, that is where I'm going. Okay, so this is a very busy slide. I can't even read it myself. But this is a study that came out from, I thought I could, but I can't, somewhere from India. That goes to show you that the degree of impoverishment, okay, and then distress in financial, catastrophic spending. And most of it, they looked at age, marital status, place of residence, your finances, level of education, religion, the type of patients, the stage, and all of them. 70%, 50% of catastrophic spending and the cause of impoverishment. Breast cancer alone. All right? So this is something to remember. So this is also another slide. I'm not good with this. Another slide, just a study that looked at Nigeria, Ghana, and Kenya in terms of the breast cancer journey. And this slide just shows you the percentage of out-of-pocket payments. At this point in time, 2020, when this was published, Ghana is the yellow, Nigeria is the green, and Kenya is the red. As you can see, the out-of-pocket payment right from diagnosis to treatment, Ghana had the highest out-of-pocket payments. And they were playing tag with Nigeria. Because at that point in time, Nigeria also didn't have any health coverage, compared to Kenya that had some form of insurance coverage. So you can see how much our patients go through in terms of out of pocket. But even me, how much do I earn? So if I have breast cancer and my treatment is not covered, I'm in trouble. So it's just to tell you what the agency of this is. So this is also a study from Nigeria looking at out of pocket payment compared to the purchasing power. Depends on our salary. The whole year, maybe you get $3,600 dollars if you are lucky, or up to £5,000. But then you can use more than half of it for your payment. There are other things that are going to suffer in your life. So if you don't have any health protection and you have breast cancer, half of your salary every month is gone. If you are lucky, it might even be more than that. This is another slide, the same thing, showing you the direct cost of treatment. This was published in 2022. And you can see, apart from your direct expenditure, your chemotherapy, your surgery, and all that, We always forget the indirect. What the health insurance is covering is only the medical costs. It's not covering the other things. Other countries have social backing as well. We don't. So it's not just the cost of treating the patients, but the person in Accra pays less than the person from Hohoe because they don't have to travel that distance. So that's, and then also loss of income. That day she can't come go and sell her wares in the Akachi market. So she's lost her income for that day. Or maybe even 3 days because the doctor says go and come 4 times a week to bring your lab results. Everybody forgets about that part of making the patient's journey comfortable. So it's not just what the government is paying, but also the expenditure that is associated with it, called indirect expenditure, lodging, travel. And somebody said it beautifully, the last video, about what it costs to get treated. For the treatment is not 1 day for cancer. Okay. So this again just shows you the impact of breast cancer diagnosis. Borrowed money, 72%. Declined treatment, more than a quarter refused treatment because of the cost. They just gave up and they went away. Some of them had to sell their possessions. That was also almost a quarter. Then you had job losses because you are taking too much time off work. So, especially if it's a private company, you are in trouble. They'll let you go. Even the government, your boss will be like, I don't think, even I do it sometimes. You're taking off too much time off work. So this is the reality of what happens when you are diagnosed. And then some people actually took their children out of school because they can't pay school fees while they are doing their cancer treatments. So or the children have to go to the market because she can't go. So then they also lost education, which is a loss to the country. But then guess what? This is a study also from Vietnam. It showed almost exactly the same thing as what was happening in Nigeria. They sold the family property 12%, 76% borrowing, 32% borrowing from the bank with interest. You know, our interest is 32%, so you are in trouble. And then also a good percent also stopped their treatment. Again, this shows you that when you are poor or near poor, then the chances of you getting any treatment is less than half. It was worse when you are poor than very poor. So the social class, unfortunately, not only that even treatment, but even the quality of the surgery is worse when you are poorer. So of course, that means that you're going to have poor outcomes. Then also another country looked at 800 cancer deaths in 4 sub-Saharan African countries. And out of these 800 cancer, there were more than 1,000 maternal orphans. So their mothers died and the kids are orphans. And you can imagine what is going to happen to those kids over there. They are going to be the delinquent ones in the roadside who will rob you down the line because they didn't get that maternal nurturement. Okay, and that is also something that is overlooked, but it's serious. Most of the women were above 50, but then look at the number of orphans that were created out of breast cancer diagnosis because these women could not afford their treatments and died from their cancer within a short period of time. Doubling the presentation time. Why is this important? Let's look at the economic contribution of women to our countries. We know the economic output is equal to the total value of goods and services produced. But a lot of women carry the unpaid care work for children, for elderly, the sick, washing, cooking, cleaning, and helping family with chores. They are not paid for this, okay? But that is why we need women to live, to make sure that our lives are going on. Then you also have unpaid work, preparing food, going for water, provision of family labor, the farms and all that. And when all of that was quantified, it was equal to 10 to 40% of GDP of a country. When it was monetarily quantified, this is what nobody does, but this report is actually from Africa. So this is how much, and this was more than what manufacturing, transport, or commerce brings. That is why women are important, and we need to safeguard their lives. All right, I'm almost done. Currently, this is what we have. I'm glad somebody went on about the basic, core, maximal, and enhanced system. We are low to middle income country. Unfortunately, the adoption of universal health care is directly related to our resources. Our parliamentarians told us that. And that's a fact we have to remember. But I think we can still do a lot better and start from somewhere. Ghana has done quite a lot. We want more. That can be difficult, but you all see why we need to invest in our women. I don't have to repeat this again. Okay? And it's the number one cancer overall. Breast cancer is the highest. So we can start from there, and lessons learned can be trickled to the other cancers. So Ghana is at the core, just from the basic. Where Ghana was used a lot as an example in this paper that was published in 2020. And what we could say that Ghana had something on breast cancer in the National Control Plan, but it was only one paragraph. Compared to Zambia, where they had 2 paragraphs on breast cancer. So that's what they are trying to say, that we don't take breast cancer seriously. So it wasn't really discussed to a larger extent. And then also we see that select cancers are covered by national insurance. And Ghana was actually giving us but it was basic treatment. So not all treatments, and I don't have to repeat this, this has been repeated by so many other people, that not everything is covered. Then in terms of reproductive health, I think we are not there yet with Ghana at all. This is our breast, so I'll leave that to rest. And also again in Ghana, it said some basic treatments are given, like hormone therapy and some chemotherapy. Radiotherapy is still patchy in some parts of Ghana, and I think that is being corrected. But then radiotherapy is very expensive, understandably, but it's a very important aspect of the treatment. And for any radiotherapy, you really can't go with the Tiku. You have to go with the Mercedes-Benz, because you might be given, maybe substandard treatment or something. So I know people think it's too expensive, but it's worth the investment to invest in radiotherapy services. Then lessons from success stories from other people. From Brazil, they established a universal health system in 1998. Everybody gets treatment free of charge. The whole country. All right? There's a centralized mammogram every 2 years between 50 and 60. So this is what we call it's tailored. They can't do every year. They couldn't afford it. So they made it at least every 2 years, to be able to cover most of the. And then they even call you. Then they're able to get the database. And based on that, they can plan for future. And then there's also a parallel private sector. So the insurance actually pays for the private sector. So you just subsidize. So if the government service is $1,000, the private, you have to find another $300 to go to the private sector. But that makes sure that everybody has at least some basic insurance. The Uruguay also was the first country in Latin America to produce universal health insurance. There's a healthcare plan for all. And that this money is brought about by income taxes of workers, civil servants, and from payroll deductions, and also from private institutions as well. So that's something that we need to learn as well. There's something like the NHIS. We don't know where it is, but hopefully it will come to the health system. But I think the basic structure is correct. But how the money is collected and where it goes is another story. But I think we need to do some more about that. But not only did they increase cost of breast cancer, but they also increased training, cancer registries, screening, diagnosis, and made sure that all the patients got their treatment within 60 days. They completed their chemotherapy cycles. They were followed for 1 year and all of that. So it's not just the treatment immediately, but everything from screening all the way to palliative care was covered. And also from Kenya, it's another country. But just the sad thing about all of this is that they're all upper to middle income countries. Okay, so resources that we do. Kenya is an upper to middle income country. And they had a case study that was published by the WHO. Their investment in breast cancer shows that for every dollar invested in breast cancer care, there was a 2.3 times investment return. So it's something, we are not throwing that money away. Sometimes our government thinks we are not. We are actually putting it back into the system twice and 2.3 times. So just remember, because you are investing in our women, and that comes a lot with economic growth. So in summary, universal health care is the only solution to reduce the high abandonment of cancer treatment across the continuum and phasing out the charlatans. Because once there's a coverage, there's no reason for anybody to do anything more. We know that our patients have their own ideas and their own wants and cares, but you've been encouraged, once there's coverage, like I said, I'll travel from Hohwe to Accra because the treatment is covered. Those are the things that will push us to improve our breast cancer. We have patients surviving for many, many years and adding to the productivity of our country. We need to improve investment outcome, contributing to the national economy. We always forget that we have to put in more money to get more out. Unfortunately, that is what it is. There's no other way. And also, we need to rebuild human resource needed for economic growth, by increasing their quality life years, and that's only by investing in the human beings. We need research and context-specific recommendations, so that we need to know that, do we need a mammogram, or even at the CHIPS compound, is anybody even examining anybody's breast at all? Those are low-hanging fruits that have not been thought of, so that breast cancer can be diagnosed early. So these are things we need to look at. We need to increase the healthcare spending budget per Abuja declaration, which is I think 50% of the GDP, but most of us are below 5%. And we need to have pilot programs starting with breast cancer, because it is the most common cancer. And then we need to rope in international funders. I think even in Zambia, they got international funders to cover their cervical cancer programs. And I think we should piggyback on that. We also have private and corporate organizations. I just hear rush all the time. Where are the others? Where is Pfizer? Where is AstraZeneca? It seems to be narrowed on the who are covering the burden. And I think it should not be so. I think this should be rolled, and everybody needs to put in their kitty to make this happen. And all other stakeholders for that matter. So I thank you very much for listening.
We can do it better for Prof. Vanderpoy. That was a very passionate presentation. And I think one of the important things that stood out was the need for partnership. One entity definitely cannot do it all. Government cannot do it all. Private sector cannot do it all. The community cannot do it all. We all have a role to play. To help us go deeper into the discussion today, we have 3 other members to join, 2 other people to join us. Okay, so the first person is from the Women's Caucus of Parliament, and if we are talking about money, we know that Parliament is definitely important. A round of applause for Mrs. Joanna AJ. The next person, we've been talking about the national health insurance since we started this discussion, and how important a role it has played in financing the treatment of breast cancer. So we have the Manager, Strategic Health Purchasing Directorate, Mrs. Doris Sadogo. A round of applause for her, please. And then we have our boss, the president of the Breast Society of Ghana, a consultant clinician oncologist at Kolebu, Dr. Hannah Aite Ani. Ladies, you're welcome. Okay, so let's set the ball rolling. A lot has been actually said from the presentation, so we'll go straight to the point. We appreciate from the presentation that our national health insurance scheme is actually doing something. First of all, let's explore the current landscape, especially from our clinicians. What's the reality on the ground when it comes to financing and then costs for treatment for patients? We are saying that the national health insurance is supposed to cover treatments of breast cancer, but you guys are the ones on the ground. What's the reality?
Okay, I'm going to start with a statement like a patient sitting by me in the consulting room. We'll be discussing, we've gone through the diagnosis, what the treatment is, what the cost is going to be. Then she says, "Doctor, shikane no chene inna kweko yen wala shinlemi." Or, "Doctor, sika we awafrei mi hu bida." That is to say, this money or this cost you have mentioned, I haven't even come across it in my lifetime. So that is the kind of discussion sometimes we have. There are other times we sit and the patient is now considering what they can start selling to be able to cover the treatment. Those are some of the extremes. There are situations where you are doing research and then you start picking the folders of those who came. Sometimes that's how you get to know those who came and never came back. Then you realize the default rate is a significant percentage. That means they heard you the first day, they went and they never came back. So those are some of the realities of the situation. The last thing I'll say is about where you have the first line of treatment. You have
the ideal. And then you've written it out. Patient goes to the pharmacy, to the nurses. The cost of treatment is given. Then the nurse comes back. Doctor, patient can't afford this. So what is the next one? And you now have to start thinking of the cheaper option of treatment. So this is just to give you an idea. I think it summarizes what we experience.
Okay, Prof, do you want to add on?
I think she's hit the nail on the head, but also to say if we came up with our own local guidelines, it will help to also direct us, because cancer treatment is not just one. There are options. So if you can't take this, this is another option. And I think what I see failing from the clinicians, we don't tend to inform the patient upfront that this is covered by health insurance. I think the first word we have to say that this is covered, but there are some times that you have to pay out of your pocket because unfortunately there are stock out that this drug is not okay. You can't afford breaks in your treatment. It has to be say this drug is not available on health insurance because it's run out. So obviously the management system, the governance systems are also lacking in terms of that. Just to make these systems as little as we have, they have to work out so that we can upscale it to get the best treatment for our patients.
Okay, thank you very much. Let's move to national health insurance. So, we're doing great so far, but let's appreciate currently the scope well. Because if I've been told I have breast cancer and I have been told that treatment is covered, as a layman, I'm not expecting to pay anything out of pocket. But then we know, as has been mentioned earlier, that even some of the times the percentages or the things that people have to pay for direct medical costs is really, really huge. So for us, you sit at NHI, can we get some initial remarks?
Thank you. Hello. Thank you. From the NHRS policies on breast cancer treatment, we cover breast cancer, some diagnosis and treatment. You can hear me? Hello? Is it okay now? Okay. From NHRS perspective, we cover some breast cancer treatment, diagnosis, and medications. For some time now, we have introduced Septin with partnership with Roche. And this is an very expensive drug. It costs about 4,000 per vial. I think it's 3,900 Ghana cedis on our list. That's huge. And let me say also that before the inclusion of Herceptin onto the NHIS benefits package, we used to record about 10 or less than breast cancer patients being treated per year. But now it's recording to around 200 patients. Yeah, so these are trials that NHIA have gone far. It's made, listening to what has happened here today, it appears as we are gathered here, it's going to be a collab for all of us to put our heads together. Patients get the right treatment. Thank you.
Thank you very much. I work with Women Caucus in Parliament, but today I'm here on my own. I said I work in Parliament with the Women Caucus, but today I'm here on my own. I'm not representing them. So I'm going to speak from my own experience, from what I've heard so far. Like the NHIS said, it's a policy and they've taken on some bit of it that they can sponsor. But from the presentation so far, it's so deep and so wide, and it covers everything. So I would suggest that the team and the researchers should engage the decision makers and the lawmakers. These things we know, but we don't know them as deep as you have presented. It has a lot, comparing countries. And I'm sure if we go through the experiences of other countries, we can pick certain things that can inform decision making and laws to improve the work of the NHIS. That's what I would say. Thank you.
Thank you very much. I just want to say that, sometimes getting our policy makers, lawmakers to the table is difficult. You would actually go out of your way to, make calls, try to get people, use others to, and it's almost impossible getting people. Today we've been very fortunate to have a lot of them here. I think we need to, we realize that it's a private public partnership. The government cannot handle it alone, and I think it's very clear. We have so many roads, and we have malaria issues, and so many other things they are handling. The communicable diseases, let alone the non-communicable diseases, which are creeping up gradually. So how do we actually sit down together to see how possible, what is the role of government? Where does it end? Where does Big Pharma come in? Where do the other stakeholders, where does the Ministry of Health come in? Where does that end? Where does Ghana Health Service come in? So we need to actually sit down at a table and see how possible. That is what we, together with the Rush Media Collaboration, that's what we're actually trying to do. We need to inform policy change, see how we can move forward, because you see, we've heard a lot about diagnosis and signs and symptoms, and how is breast cancer caused. We've heard that so many times. When it comes to the reality, when our Breast Society or office line is active and people are calling because they don't have food to eat, and those are some of the calls Gina gets. Then she needs money to buy food to eat. That is, that's as low as that, and she receives so many of such calls. Even during her patient navigation, the surgical, look, you should hear the kind of complaints. People are hungry. They do not even have enough to pay for their treatment, to eat, first of all, even to pay for their treatment, to pay for children's school fees. So these are to really look at the way forward. There are times we do screening exercise. We've diagnosed patients with breast cancer. Then you give them the referral. Go to Kolebu Teaching Hospital and so and so. If they don't have money, will they come there? There are times patients come and tell me, Doctor, I'm a transport money. And you have to do that, So we really have a problem. And I think we need we need that embodiment. We need every one of us to have the same goal. So we sit, when we call our big people to come together, let us all sit down and see what can we do individually. How can we partner to get this going? And that's where Breast Society of Ghana wants to be. So we want to tell our partners that we will be approaching them. And we know that we are glad to have the Women's Caucus, so we will be coming. So when we come and we have a meeting, let's sit and discuss it together. We tried to get our first ladies here. Unfortunately, we were able to get the videos. They couldn't come in person. We know they are campaigning all over Ghana. We are campaigning, but the truth of the matter is there are subtle problems which need to be solved. So let's move together.
I think you started a very important aspect of the discussion. Most of the cost is not just the direct medical cost, but there's a huge chunk that's indirect. And there was one study I looked at that mentioned even transportation. Even from the video we watched before this, transportation is a huge one. Now that we are talking about partnerships and collaborations, something like transportation, what are some of the innovative things we can think about that can help? Because some of the resources, the diagnostic tools, as we said, people have to travel from the north to Accra. So transportation is a very, very huge cost.
I think we are talking about decentralization of care here. To be safe decentralization. I know we all want to adopt this, but be safe, so that you are treated by the right person at the right time. But I think, like Dr. Aite said, a lot of things can be done through Zoom and telemedicine to discuss the patient start first. And I mean, treatments can be started in the regions by the correct people. Again, it needs investment in the government to make sure that these patients, she, in her presentation, she mentioned it, increase the capabilities of some of the hospitals in the minimum, the regional hospitals. And then maybe we are not sensitive to the patient's cost, in prescribing the chemo. Make it convenient for the patient. Don't let them come every week, every 2 weeks, when do an x-ray, when it could have been done from the beginning. I think that we don't realize how much even it's important. Go and do your labs. Meanwhile, she just bought one last week. These are very sensitive things that we tend to ignore to make these things easier. And the labs probably can be, or some things can be done. Just see your doctor out there. When there's a problem, then you come to the hospital. But people want the patients to come every month for review. But maybe it's just 2 minutes with you examining the patient. It can be done in the district. And then when there's a problem, there's little things that we can do to make it. But most importantly, the government has to invest in upgrading the regional hospitals and the district hospitals to give some basic treatment. With radiotherapy, they've changed the fractionation. It used to be 6 weeks for radiotherapy for the breast. But now, even in high-income countries, it's 5 days. But then the quality of the equipment comes in. So we need the Mercedes-Benz to be able to do this. So the patient only counts for a week. But you can see how much savings, how much economic, development you can gain from that woman going back and selling her things or taking care of her children. We look at it even in the small picture, but there's lots that can come out of it.
Thank you, Prof. Vanderpoy. We are also trying to look at the possibility of starting a cancer foundation for Breast Society of Ghana towards that. We know that this can be a fairly challenging journey, because usually to have a foundation, we need the lawyers, we need all of that. We need to be sure that when we have that going, we know exactly who are we funding, where is the support coming from, who are the target population, who can we actually support for breast cancer treatment. I think such a thing will even include those entrepreneurial organizations and all, who can even provide probably things as simple as foodstuff and others to help patients who are going through difficult times. So I think this is a call for all who have breast cancer dear at heart. When we eventually start and roll this out, we will be able to get good support, a good foundation base to be able to help support, even if it means paying for someone's chest x-ray, someone's blood test, etc. We can do that together. Thank you.
Let me take the advantage to inform the team that 8th March of every year is a big day for Women's Caucus in Parliament. We celebrate Women's International Women's Day. That's the day we have chosen to celebrate women with breast cancer and cervical cancer. So you can knock on our door on that day and give us the information.
Okay. Because of time, let's just go back to National Health Insurance. Let's talk about sustainability and then long-term plans in terms of financing treatment. I know currently it's treatment, right, and screening is also not part. So in terms of long-term, are there any other aspects we are considering to ensure that the treatment is, if we say it's covered, fully covered?
Okay, I think it's fine. NHI is open to expand based on the needs of the population. So I, on my side, have not come across that yet, but it's something that can be taken away from here and informed the appropriate people. The Prof presentation stated, I like her lessons, and those are some of the benchmarks that we can take away from here. And then making treatment more accessible to breast cancer patients.
So,
I think as a follow-up to that, I would like to ask, maybe you could also tell the director, NHI. I mean, I've spoken about this, the executive management. Okay, thank you. So I've spoken about it, that, you know, the NHI is supposed to be, it's across board, one sort of. Why don't we have, even though we have private mutual, I mean, insurance companies, we have a situation where they are great, can be the standard, they can be the premium. So I'm still NHIA, but I can pay for premium service. So then I pay a little more money. So if I decide I want to do 500 Ghana cedis every month, it's still insurance, but there are gradations in it. So it's not the local one for everybody, but they are. And people can, I mean, you could also think, if you're looking further, why can't I insure my breast or my prostate? Insuring my breast against breast cancer. I'm insuring my prostate against. I think we should move forward beyond just one level. Thank you.
I think I also add that maybe the structures might be, we are all depending on the SNIT. We know SNIT has its own issues. But we should look at income tax, so that in one of the countries, I think it was Uruguay, they did the taxes based on your income level. You understand? And that helped towards the national health incentive. Yes, and then also the corporates, their profits. The banks make a lot of money. They announce it every time. So a percentage of it, not 12.5%, but more, can go towards the health budgets. So this, and like you said, most people don't want to come to Kolibu as well. There's a long waiting time, a lot of people. So I think the private aspect, and everybody who needs her septic has to come to Kolibu, I don't think is really right. You understand? And so it also, burnout is also another issue, because there are so few, oncologists and whatnot. So it's something that we should remember.
So I think these are very important long-term things when it comes to the insurance. But before we wrap up our discussion, let's look at, we've mentioned private sector partnership, the community. Can we be specific as well in terms of long-term sustainability? What specific roles private sector, is pushed to help with the whole treatment campaign financing, as well as the community? And this will be our last words as we open up the discussion.
For me, I think that it's like a crowdfunding. So like Rush came to you to help to supply acceptance. They came to apply that this is something that is doable. I'm sure they are making money, but it costs so much more. The same drug costs 100 times more in the United States. You understand? So these are things that other companies. Why should one person be carrying all the burden? I say it all the time. I'm not shy to say that. You understand? So I think that other companies should also come on board to make some of these. The thing is that breast cancer patients live so long. Most of my patients, they will outlive me. Metastatic, the average survival for patients who have bone metastasis only is about 3 to 5 years. But unfortunately, they have to be on medication to attain these 3 to 5 years. So their drugs are not from Roche. They are from other companies, but they are not coming on board to help. But I think the crowdfunding, the volume, like you said, the number of patients are increasing. You understand? So that is what we need. The crowdfunding, we have to come up with some new mechanisms, research to come up with more mechanisms to make this happen.
Thank you very much. I also want to say that, looking at from the government point of view, I'll give you one example. I had a patient who was a surgeon, had colorectal cancer. Now we needed some medication. We needed to get particular medication for him. So we went through Merck in Germany. And they graciously gave us 3 months free supply of the medication. The medication got to Ghana's borders. The patient paid a huge tax. This is a doctor, a surgeon who unfortunately had colorectal cancer. He paid huge sum of money to get the medication from the port. Medication that was given free by Merck. Does that make sense? It does not. So I think that if we can remove whatever tax. You see, we are trying to, if this is a roundtable discussion, that means everyone is doing their part. Because when you put significant tax on the medication, what happens? The pharmaceutical company also has to make up. So in the long run, who pays? They add on just to make, in the long run, it's the patient who pays. The patient who has no money will pay for that tax that farmer paid for at the border. And in the long run, what happens? Then they decide, I don't have money, so I will sit at home. So I think we can start from there. Government has a part to play, even if it's to do with tax. The lawmakers also have a part to play to also put in the right laws that will push the message, that will ease things. Ministry of Health has a part to play. Ghana Health Service has a part to play, right from CHIPS compound all the way up. The NGOs have a part to play. Even our chiefs and our fathers and mothers of the community have a big part to play in moving this across. The patient, the survivor, has a role to play, because usually there are some countries where survivors have spoken out. There's one country where the survivors decided, told the government that they were going to go topless and demonstrate if they didn't.
Are we getting there?
You know, if they didn't provide radiotherapy, short time radiotherapy much, one of our West African countries. So you see, sometimes we need to talk, but because of stigma, people will sit and not say anything because she doesn't want Mrs. A to know she had breast cancer. There are patients who are lawmakers. There are patients who are in the ministries. There are patients who are top officials in the country. Yet, you will never hear any advocacy from that role, because even those close to them, they do not want to know. So how do we fight for breast cancer? I think that's where it starts.
Are we ready to talk? Are we ready to talk? Okay, let me get the last words from NHI and then.
Like I said earlier, NHI is always open to expansion based on our needs. So what have been discussed here will be taken forward. Then we will see the way forward. That's all I can say for now.
Okay. I'll also emphasize and stress on the fact that the partnership between the team that is working on these issues, between the decision makers, the lawmakers, should be deepened so that they will understand what we are dealing with. I've heard a lot and I've seen a lot, but what I'm hearing here is just different from what we hear outside there. And I'm sure it goes to most of the members of parliament and things. Women caucus, we do breast and cervical cancer screening every year in their constituencies. But this information is just something different at a different level altogether. So if they are informed and they get the understanding, they can also convince their people to come. Sometimes they go set up their tables and things. We send the medical team there, and we don't get the women to come. Yeah. So I think it's a good platform for us to start moving on. Thank you.
A round of applause for my esteemed panelists. I think the panel discussion has been very, very good. We've highlighted the fact that financing breast cancer treatment is not just a healthcare issue. It's a social issue, it's an economic issue, and we all have a role to play. So at this point, I'll open up for a few.
So let me stand there and use my crutchy power a little bit as a chair to talk about this. For some of us, we've been in this journey for about 20 years with Prof. Clemente and Dr. Verna, and we are very happy. Those days when you say cancer care, will not be more than 10 people in the room. So today, to have a lot of people, this is good. And frankly, I'm happy we don't have the first ladies here, and we don't have the Minister of Health here, because every person here in this room now is somebody who has continuity. Thankfully, the MPC have safe seats, so they are coming back. She says she works with Women Caucus, so she's there. And I looked at her, and she's not up to 60, so she has a long time to go. And Gamanche and his reps are here. So we can give ourselves in the next 5 years to change the face. At least Breast Society has to also evolve from a clinical organization, and now we are talking advocacy. We have more patients in the room than we, the healthcare professionals. So the next 5 years, something has to change. Something has to change, and it has to start with all of us now. As Prof. Bernard rightly said, when you go to Mauritius now, everything cancer care is free because they did something very simple. All the things, they introduced what they call centers. The things that you are using for fun that can cause health care, tobacco, alcohol, all those things, they tax them big, up to like 30%. Then they put all that money into health care, including cancer care. The number of if you go to where I came from in Kumasi, every Saturday, the alcohol that is drunk, and in the evening now they've even introduced dinner for funeral. Honorable, if we tax that alcohol, if we tax that tobacco, and we say that we are using it to fund cancer care, in the next 5 years, we have radiotherapy machine in the north. We have tamoxifen. We will address all the gaps that the Dr. was talking about. Mammogram here, something there. And I remember very well myself and Proven, I don't know. Do you remember how come we got the list of chemotherapy into this health insurance? We did a subgroup in that group. And that was how many years ago? Long time, over 10, 12 years ago. We just said that we wrote the chemotherapy that has to be reimbursed. So nobody stopped us. What we wrote is what is being reimbursed now. And what we wrote has to be covered is what is being covered now. It has never been reviewed because nobody has approached them to review it. Nobody. We have not approached them. We are the technocrats. So please, we cannot blame health insurance. If today health insurance is not paying for the diagnostic, they are not paying for the newer medicines because we have not gone. So Breast Society has to move. We have to help to integrate and do all this. So please, we need to have a 5-year plan. And please, we are going to call on you, Women Caucus, MPs, and I thank God that you are a medical doctor and there you are there. So please, the solution is here. And we use the strong face of Gamanche to say, in the next 5 years, this is how we want breast cancer care and cancer care in Ghana to look like. And when we approach them, we will do it. And please, so if there's an outcome out of this, we have to get to the point where in Morocco, the princess, the wife of the king, all cancer patients who are going for treatment, they bought buses for free. They don't pay. So we need to create these survival solutions. And if we don't give them the solution, they will not. There are so many things. They have gutters to think about. They have markets to think about. We have to go with the solution. So I really like the suggestion that you made. We look at how the patients, we move from complaining to giving solutions and using you to going to be solving. So tomorrow, as we go into our AGM, we will leave there with the solution. And please, we'll come back to you and then we all do this together. Thanks so much.
Thank you very much. So we have the solution. There's a hand.
So we are zooming straight into the question and answers. It's already started.
Thank you very much. My name is Mary Idrisu. I'm a nurse researcher from the University of Ghana. I have 2 issues to bring on board. I did a study, a 1-year ethnographic study that studied factors influencing breast cancer care from the patient's perspective up to the policy decision-making level. Now, I came up with policy decision issues. National health insurance says we cover breast cancer care. But then I met patients who went to facilities and they were told to pay. And then when I contacted National Health Insurance, they told me we cannot witch hunt our providers. And for that matter, if we have given a short code out, the patients are supposed to call and tell us that monies were taken from us. Again, procurement complexities. There are facilities in Ghana that are providing breast cancer care. However, they do not procure the chemo medications. So it is a challenge. Patients traveled all the way somewhere from Eastern region to Accra to purchase the chemo medications. And this has given some healthcare professionals the chance to procure these drugs. I don't know how they get it into their lockers, and they are selling to patients. And as I was coming, somebody told me, when you go to the program and you meet the Kolebu doctors, tell them I didn't come because I lost my sister 3 days ago. They said there is something called intramural. We need to pay. I paid. I was never seen. And 3 days ago, I lost my sister. This is a beautiful lady who completed her master's barely 2 months ago. A sad story. We are facing realities. So there is a policy implementation gap. You are treating breast cancer with health insurance. You are also diagnosing. But then the policies are out there. Who is monitoring its implementation? Yes, so I think that let's look at these issues holistically. I am pleading, please. Thank you.
Thank you so much. Prof. Cleglante would like to respond.
No, I'm not responding. I'm making my own contribution. And National Health Insurance is here. Obviously, she's very shy. She can't say certain things. We can't blame National Health Insurance too much. I'm glad policymakers are also here. We collect so much money for health insurance. You are taxed for national. When you go and buy something in the shop, you pay national health. You pay, You can ask her how much of that money is given to them. The money is capped, and they get only small amount of money. So I beg policymakers, we are collecting the money. Let's give it to. If they have the money, they will use it. But they don't have the money, and she can't say it. So I'm speaking for her.
I think one of the major problems is also the fact that the fees we are paying to some of these facilities doesn't match up if they were to take cash from patients. So sometimes some of these services are available, but they tell them that it's not. Because those who are paying the fees would pay sometimes 3 times, 4 times more than what NHI is paying to some of these facilities. So long term, please review your prices.
They are actually under review, both the tariffs and then the medicines list. But from what she said, I think it may not be entirely an NHIS issue, but I can tell it's due to our reimbursements. We don't pay early, we delay so much. So sometimes providers will just tell patients that it is not covered, yet it is covered, because once you give service out, it probably will take you some time before they are reimbursed. And sometimes that's where we see the challenge. And as we are all partners here, maybe moving forward, we need to change.
Yes. So, Honorable would like to share a remark in response to these sentiments that have been shared.
This issue of NHIA to a large extent is not to blame. Like Prof said, they are not to blame. The law says when you take this money, within a matter of 30 days, it should be lodged in the account and the minister duly informed, that's the Minister of Health, and the NHIA be informed so that they can touch it. But these monies are deducted, they are diverted. They are not lodged there. They don't listen to the law. That is Section 52 of the NHIA law. It's there. They don't adhere to it at all. Why we as members of a committee, we fought Honorable Ken Oforiatta to decap the health facilities. He refused until he left office. We did all we could. We did all we could that those facilities should be decapped. We are not even able to meet the Abuja Declaration. And the little money they generate to, we go back to cap it. For what? So some of these things, we create it ourselves. As for Parliament, don't blame us. We fight on your behalf. But, yes, we fight seriously on your behalf. But the executive is too powerful.
Thank you, Honorable, for that insight. There's a quick remark online, then I come to Dr. Na. The suggestion online, we don't have the sender yet. I mean, I think it was a bit of an anonymous. He says, please, I suggest the Breast Society of Ghana can also collaborate with the Ghana Education Service, since they have a fund that supports cancer treatment, to organize quarterly breast cancer education and screening for teachers across the country. I think that's a very brilliant idea.
I just want to reiterate something that Dr. Annie said. And honestly, there are a lot of things that I don't understand. I hear I'm quite blunt. But there are so many things that I don't understand about the way we do things. I don't understand why now Doko IET, I have to pay, I think, 13 cedis for health insurance. The reason is because I pay SNET, which is all good. But realistically, I can pay more for health insurance. But because of politics, we want everybody to pay a certain low amount. And even that amount of money we've been told will not go to health insurance. It's quite frustrating. And we always meet, we have a long talk, and then next year we meet again and it's the same thing. Maybe we really should go topless. Something has to give. You see patients who come to the hospital, they don't even have food to eat. And you are telling them to pay 4,000 cedis, 12,000 cedis. That is 120 million. They cannot afford it. And we are having to make changes to the treatment. Oh, you can't afford this, so let's do this one. Why? Why? Maybe women, we should go topless. Maybe when we go topless and we are crying, they will understand. And we have neighboring countries that have achieved so much. We don't even have to reinvent the wheel. People have done it. Let's look at them and repeat. Why can't I pay more for national health insurance? I want to pay more for national health insurance. It should be possible. Everywhere in the world, the rich are taxed so that the poor will benefit. In any case, we don't have a level playing field. Some people are born in Accra, they will go to international school, and they will become doctors. And so what? But the person who is selling or whatever, digging, they are the ones who can't afford. Why can't the rich people use their money to help pay for their treatment? And all of this, they've capped this, what are the words that they use every day on radio? Consolidated it, they've used it for our and all of those things. We must think about our people. Ghanaians are getting tired though. We are getting to the point where we will go topless very soon.
Round of applause.
Thank you. Thank you.
And we'll take just one last. We'll take one last. NHI, please, I hope you've noted all our points and you are going to communicate it as such.
Hello, my name is Andrew. I'm a scientist. NHIS. In Ghana here, we have a policy. When you are not sick, you don't go for checkup. Is it not true? So why can't you change the model? Make it preventive. Where the preventive becomes more. People do a lot of checkups. I haven't gone outside, but I know they get phone calls for pap smear screening, for breast screening. My uncle came here, stayed in Ghana for 1 year. They got him to check your teeth. He flew to Canada and did it because he know his money is tied to it. So why can't we do the same here? Because we know that when you are sick, the cost, as Madam said, the cost is a lot. The cost is a lot. So if we can change the model a bit, we should look at that side. Thank you.
Thank you.
Thank you very much. This is to the end of panel 3. We hope that all the beautiful ideas that have come up, hopefully in the next few years, we'll see them all become a reality. I'm hoping one day, when someone is diagnosed of having breast cancer, irrespective of all the numerous problems the person would think about or consider, finance, hopefully, shouldn't be one of them. Thank you very much to my amazing panel.
I'm excited when usually we have an all-women panel, and I think they did not disappoint us. It was highly insightful. It's good that we have honorable members of parliament here. At least the women have already sounded a bit of a health war drum, that if we don't change the system we are operating, they will go topless. And I fully concur with that arrangement. Something must give. Something definitely must give. We have been we have been always joined by those online. We want to say thank you. We see that the numbers online, whether on Facebook, whether on YouTube, whether on Google Meet, has been very stable. The numbers keep even rising. That means that whatever we are doing here, people really appreciate it. For those online, we really thank you. Even though you are not physically here with us, you have kept fidelity by staying online with us throughout the event. We will take, we have 2 short remarks. The first will be from the Associate Director of Policy and Health Systems Strengthening for MSD in Sub-Saharan Africa. And then after that, we'll take another address from Dr. I'll have to take my time and pronounce the name correctly. Hoktato Mutumi. Dr. I usually would prefer to call her KG because the pronunciation, you need to speak from your throat the way she pronounced it. Hoktato Mutumi. She is the general manager for Roche Products Ghana. So that will be the flow, and then we have our chairman. So at this point, let's take the short address from Dr. Numbuso Nkabuli, who is the Associate Director of Policy and Health Strengthening. It will be prefaced by a brief video, and then she will give us a short remark.
How do we help secure a healthier future for everyone? By seeing things in ways others don't. Here at MSD, we are purpose-driven, with a commitment to making an impact that's sustainable. To us, doing good for the long term and operating responsibly are one and the same. That's why for all we've created insights and vaccines in response to outbreaks and urgent needs, working to improve access so life-saving medicines reach those who depend on them, and investing billions of dollars in R&D, targeting diseases where we can make the greatest difference. Our Fellowship for Global Health sends employees around the world to take on health challenges, transforming hardship into hope. For more than 30 years, we've been fighting river blindness to eliminate this devastating disease. And MSD for Mothers helps make pregnancy and childbirth safer for women everywhere. We continue our efforts to help protect the environment, We're shifting to renewable energy sources, reducing water use, and utilizing recyclable materials in our products and packaging. For over 125 years, we've recognized that the health of our business and the health of the global community are intertwined. So we work with partners as committed as we are. Through partnership, investment, and endless invention, we will overcome barriers to providing a healthier future for all. Not just for the next quarter, but the next quarter century.
Okay, on this note, let's invite Dr. Mumbus.
Thank you very much. Representative of His Royal Majesty, Ni Ahene Nuno II, Honorable Members of Parliament of the Republic of Ghana, President and committee members of the Breast Society of Ghana, fellow industry colleagues, esteemed guests. Ladies and gentlemen, it is an honor to address you today on behalf of MSD. Like our members of Parliament, I believe that my seat at MSD is safe. We have been operating in sub-Saharan Africa for more than 50 years. However, even if my seat isn't safe, I'm happy to share that MSD is here to stay. I am from South Africa, and as somebody who travels frequently across this continent, I can genuinely say to you all, hand on heart, that there is no country that I anticipate visiting more than Ghana. I'm very grateful for the warm welcome that I've received here and the spirit of Akwaba that greets me each time I come here. I'm deeply humbled to stand before such an esteemed gathering at the Breast Cancer Stakeholder Forum and Annual General Meeting. My career journey has taken me through clinical practice and public health, ultimately leading me to MSD, a pioneering pharmaceutical company. This trajectory has offered me profound insights into the challenges that cancer patients grapple with on a daily basis. But insights do not equal personal experience. And the personal stories that have been shared by our warriors, our breast cancer survivors today, I just want to say that we are here to honor you and to advocate with you. I also want to share that it is my hope that next time that we engage in esteemed forums like this in Ghana, that we can also hear the stories of our sisters who are survivors of cervical cancer and advocate for them just as passionately as we have done so today. The experts in the room will know the statistics for the burden of disease much better than me, and a lot has been shared today. But according to global cancer registries, breast and cervical cancer account for half of all cancers that affect women in Ghana. But we know, and we have heard many times today, that the reality of the data, the patient's journey, and the treatment outcomes are far worse. Immunotherapy has emerged as a revolutionary approach in combating breast and cervical cancer. Recognizing its potential, MSD is unwavering in our commitments to serving the unmet health needs of patients and survivors in Ghana. We are dedicated to driving awareness for women's cancers and fostering partnerships with various stakeholders across the continent and in Ghana, including with associations like our gracious host today, the Breast Society of Ghana, NGOs and civil society organizations like Challenge Kumasi, the private sector, and government entities in order to ensure equitable access to innovative treatments and comprehensive care for the women who are battling these cancers. I'm pleased to share that MSD has an expanding commercial footprint across the continent, which is a testament to our commitment to serving the needs of women affected by breast and cervical cancer. And as on this expansion, I sincerely hope that the esteemed stakeholders gathered in this room today will continue to join hands and join forces with us on our shared mission to improve the lives of those impacted by these devastating diseases. The role of public-private partnerships is critical in revitalizing healthcare, particularly in the face of resource constraints that we face across our continent. Today, we have heard that the impact of cervical and breast cancer extends far beyond the individual. It deeply affects families, communities, and the socio-economic fabric of society. MSD is deeply committed to advancing initiatives such as the WHO's 90-70-90 strategy for the elimination of cervical cancer. And I would like to congratulate the government of the Republic of Ghana on the planned introduction of your HPV National Immunization Program, which is a critical step in advancing the strategy. As the pioneer of leading immunotherapy treatments, MSD is steadfast in our dedication to further research in the challenging oncology landscape. Our goal remains to improve access to innovative treatments and provide hope for those affected by triple-negative breast cancer, cervical cancer, and other difficult-to-treat cancers. The difficulty of treating cancer is evolving, with innovative therapies that now extend survivorship, like immunotherapy. However, when I draw on previous experiences, and as I've heard from fellow clinicians today, conveying the bad news of a cancer diagnosis has always been a difficult task. I will always remember my initial encounter with an advanced cervical cancer patient, a mother of 3, and the unmistakable signs of aggressive metastatic breast cancer in a young woman who was just about to start her first job in South Africa. Sharing that heartbreaking news was a difficult task, and for the woman hearing that news, it must have been unbearable. Unfortunately, breaking and receiving bad news never becomes easier. Yet, I remain hopeful that what can become easier and what can become more manageable is the availability of cancer education, the availability of vaccines, as well as screening and diagnostic services, all aimed at achieving early diagnosis. And also, all aimed at leveling the treatment options playing field between the West and the global South. My aspiration is that by equipping women with knowledge and with resources, the delivery of bad news will be followed by a range of treatment options rather than an inevitable death sentence. In conclusion, I wish to reiterate MSD's commitment to women's health in Ghana. Our efforts reflect our deep appreciation for the resilience and the sacrifices of African women. We remain steadfast in our determination to unlock the full potential of the continent and to improve the lives of women affected by breast and cervical cancer. Oyewaladon. Thank you.
Now, that's an interesting one, you know. I think you, aside Akwaba, Oyewaladon, that's a good one. Okay, so thank you so much, D. We have the honorable presence of the director for Ghana Health Service, Family Health. She had to depart prematurely owing to an assignment, but she left a very insightful message for us, for the Breast Society of Ghana, and I read. The Ghana Health Service is pleased to be part of this great campaign, and they agree that the collaboration is the way to go. The service will hold a nationwide health education activity in all facilities, and they are also committed to undertaking free screening for all staff and some community members. Also, they are organizing staff to also join the main walk in October, and they don't want to duplicate the efforts, rather they want to delegate duties and intensify their strategic priority actions aimed at prevention, early detection, and the full free care for all affected women. Even though she had to leave prematurely, she definitely is in very good spirit with us in whatever we are doing here. At this point, I would like to invite the general manager for Roche, and she is in the person of Dr. KG. Let's do it for her. I want to be safe, so I'll prefer calling her Dr. KG. I'm sure she will mention the name for us all to take very good note of that. Thank you so much, Dr. KG.
Thank you very much. Thank you very much. That was actually a very impressive attempt. So for those interested in the name, it's Hotato. And I want to warn you, because Dr. Vanderpoel just pointed out, there's so many South Africans in the room. If you ask them to say it, about half of them can't say it. So don't worry about this. And really, I'd like to thank you. I'd like to thank BSoG for this meeting. My heart has been so happy. As Mr. Charles Fojo, it's his doctor of how much work he's been doing over the years. But really, as he mentioned a couple of years ago when we talked about cancer, this was not a conversation for a lot of people. It was a scary conversation that people didn't even want to interact with. So to be able to stand here in 2024 and have so many parts of our environment in this room, our ecosystem, members of parliament, our chief, our doctors, our NHIA, to be able to sit in a room and have this debate with each other just gives you an indication of how much work has gone into this and how valuable this conversation is. So before I even go into my small chat, I just wanted to thank every single member of the people who are sitting here and having this conversation, because this is an important conversation to have. Mothers are dying, and we need to do something about that. So I really would like to thank and introduce myself with my Ghanaian name, which is Akusua. And really just give a brief outline of who we are as Roche. I stand here in front of you on behalf of my team, who have been in this country from around 1997. Charles, you have to correct me. And really what we've tried to do over the years is to make sure that when we go into an ecosystem, we build the ecosystem so that we're able to have a sustainable future in the ecosystem. And I think, yes, I know Dr. Vanderpoel said, is it Roche? It's not. I think what's different about our approach has been the consistency of the approach. And that is my invite to actually everyone in the room. This is a long journey that is complex. There's no easy solutions. And because of that, we have to be consistent in our approach, and we have to be consistent in staying and fighting this war. This war on cancer is real. Real women leave children to be raised by strangers. And this is not something that can stand. So on behalf of Roche, I just want to explain what we've been doing with the NHIA. I know she fielded a lot of questions, but a lot of work has been done. The MOH and NHIA have been working with us since 2018 when we signed the agreement to make sure that we try to make it possible that the treatment is available for free to the patients when they access the public service. What then happens is, what we all learn over time, of course, is that even though we move from 2 centers to 5 centers that we've been working with them on, even though more women today are accessing the treatment than when we started in 2018, what then happens is all the other things that were mentioned, the socioeconomic factors, hamper that and get in the way. So what I would like to say is a commitment from Roche to say we are intending to stay, and we're intending to make sure that the women of Ghana get to live to see their children finish school and become adults and thriving members of society. So what my call today has been, going to do a whole long speech about things we've done, but I actually am much more proud to say there's people there joining this war with us, because this is an ongoing journey and it matters to all of us. So what I'd like to actually just ask is, the more action for journey that's been alive. And I'd like to really ask us to also think about our individual role that Dr. Anchi mentioned in her address. The individual role that, because this is an ongoing journey. And as one of the patient survivors mentioned, she decided to be an advocate for change. And that is my action today, to say, can we all be an agent for change and make sure that mothers gets to live long enough to ride her bicycle tomorrow, go to work, and actually bring a life. So thank you, and I hope you have enjoyed the rest of the day.
Okay, thank you so much, Dr. KG. We have 2 quick videos, and then we call our honorable chairman to bring the day to a successful end. The last video, that's a message from the last video will be on from the second lady of Ghana, Mrs. Samira Baumia.
Hello, my name is Mrs. Samira Baumia. Do you know that unfortunately about 1,000 women in Ghana lose their lives every year due to breast cancer? Unfortunately, many women do not seek early treatment and do not follow prescribed treatments. However, regular screening and mammograms can detect cancer early. So please remember, early detection and effective treatment save lives.
Okay, before we have our chairman's final remarks, I would like to kindly inform the House that there are iPads out there in the foyer, about 4 or 5 of them. There which patients with patient stories loaded on them. You can use headsets to listen to the various patient stories. We captured that so that at least everyone leaves here fully attached and also cognizance of the challenges that various patients face within their patient journey when it comes to breast cancer. This is for us a solemn call to everyone here present to kindly take time to listen to these patient stories. The iPads are out there in the foyer. I'll call Dr. Akwesi Anyanfo to step in as we wait for our chairman to wrap up the day for us. We would have photo op sessions, and we would call the various retinue to help us accordingly. Tomorrow we also reconvene here, same room. We start exactly at 9 o'clock, but we would appreciate if we don't make it Ghana time. It has to be exactly 9 a.m. so that we can leave to our various homes, especially being on a Friday early. Thank you so much.
Thank you, Reginald. Our chairman is just doing a short interview, so he'll be with us soon to give his closing remarks. So like I said, tomorrow 9 o'clock. Today, I apologize for us being late, but normally the first day with all these systems, it was a bit of, at least we are 45 minutes late. Lunch is served, is ready. When you get to the foyer, the lobby, just take the right one as if you are going out. They set the place up for us, so that's where we have our lunch. And then on October 26th, on October, the first Friday in October, we will launch our October activities. So we will let you be aware. That's why I said anybody here who wants to be with us all the way, please leave your WhatsApp number there so that we can add you to our WhatsApp group. That's why we send most of the information. We also send it also by email, but I think most people read WhatsApp. So first Friday in October, we will launch our October activities. And then on 26th October, which unfortunately has clashed with the EBRI program, we will see how we will division ourselves into twice. We have the breast cancer awareness walk. So parliamentarians, they've agreed to join us, Women Caucus. So it's going to be a big walk. We're planning for 1,000. Speaker of Parliament says, we will have the motorcade behind him in case he gets tired. So even though we call it a 100-man walk, It is not 100, 1,000 man work. It's not men only. It's man in the Bible. So it's a work, breast cancer awareness work. So we've gotten the Independence Square. We are just trying to a few things here and there, and then we'll keep you informed. But it is on the 6th of October, Saturday, 26th October, we'll have the breast cancer awareness walk. We hope it to be not 1,000, but over 10,000. So I'll leave the MC now.
Before even Dr. Anyafu resumes his seat, I think I want him to briefly share with us how to become a member of the Breast Society. That makes it easy, because I hear a lot of such questions from the back. So if you can briefly share with us, then we invite our honorable chairman to bring the event to an end for today. Thank you.
So for those who want to join right now, at the table, you can just register your name and then join. But then for those who want to join maybe later, if you have not have time today, just Google Breast Society of Ghana and it will appear. And one of the icons is register to be a member. So you just register and then automatically it comes to you. Is there any more? The last video. Oh, I didn't know.
So I'm told that some people didn't hear the message about how to join. Breast Society does have an online website. If you Google Breast Society of Ghana, the very first two items that pop up is the website of the Breast Society. It's a very interactive website. You will see register. Once you click that, the information they are asking for, you can easily provide. Alternatively, there's a table outside just where we registered. You can do the same thing by sharing your details with them, whether it's your email, your phone number, WhatsApp number, whatever it is. We can easily reach out to you whenever we are having programs. So those are the two modalities you can use to join. We'll take the last video and then we take our remarks from chairman, media team.
But I wouldn't break for you. You couldn't take my heart. 'Cause every day I've been getting stronger. So you can't break my spirit any longer. 'Cause I'm gonna find my girl. I'm gonna take my stand. I'm gonna stay wanting God to go right where I am. I'm gonna see why. No, 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 I'm gonna claim my faith and have no fear. 'Cause I'm a body, I'm a star. You're gonna change my world. 'Cause I'm gonna find my girl. And when this mess is over, it's my name, baby, yeah. I'm a soldier, I'll be a warrior. I'm there in that hell. You thought you had me up against the road.
That short video, our honorable chairman, Ni Ahine Nuno, the third of the Abola tradition area, representing His Royal Majesty. We thank you for being our chairman, but obviously we need to hear your final remarks before we can exit from this place. Ni Ofaine.
I would like to thank our mighty God for giving us today, and the program became a very good one, a successful one. I would like to speak in my local language now. If you're Miyake, breast cancer, in my opening speech, in Miyake, Fufo and Woyu, Fufo, Kenya Akwe, wo MPs nutule joame ametashi amemewo ejake lokoni ngbawona igba aka ashantenyuna igba aigbenyuna igba wo fe wona je Ghana pe the whole world. Ni wobani wokwe ni leken libi ne wo mitigate ekume. No kenya akwe wo panelist. To wo professionals ni ba wie ame wie bonu wobani wo fe. Ko mo lo ya obana no ya oba survive NHIS libi ni wonue nyoni nye ane ni anyaka nye bosses egaga libi efen wo yo side effect ye ni kenya nye ka ba wo mi ko ni side effect no ni ba ni bon kete kanshilente e ba jole ke libi ni awie ne madanye fenshi ke libi ni wo ya ne wo fen wo ya nwa hie anu ni wonu ye bi ne ni wonyemi wo mami wo nako ke e ana le ken hila ne edwen alo ya ko ni ya check health worker ni baba if you an go fen work we ba wo mi ya ne inkuchu ni je ke manche ni yo ken tepe mu mana mele wo fen work we ya wo mi ni fi awareness ya mo nye wa don.
The chairman has spoken. He spoke in Ga, highfalutin Ga, I must be specific. And just to bring our colleagues who have traveled from all over the world to what Ni shared with us. He started off by saying that despite the busy schedule of our honorable MPs, they saw it fit to join us here today. Paramountly, there has been several deliberations by all stakeholders who sat here trying to tease out pragmatic ways of solving the issues of breast cancer. But more importantly, there's an African adage that says that when it rains, it does not rain in one person's house. Whether you are an Akan, whether you are a Gan, you are an Ewe, whichever tribe or whichever denomination you find yourself in or you identify as, breast cancer is able to, happens to all men, just as the fate of all men is. So as much as possible, finally, the National Health Insurance should as much as possible communicate all the sentiments that have been shared, because there were a lot of issues about reimbursement, about the unavailability of certain medicines and all that. That is the gravamen of our remarks. I hope I was able to summarize that for the Honorable House. On this, at this juncture, I want to again call Dr. Akwesi Anyafo, who will give us the vote of thanks, and then we take the photographs and then media interactions. Thank you so much, my dear audience. You have kept fidelity with me and the rest of the scene.
Thank you very much, Reginald. So everything must come to an end, and we have come to the end of today's program. But we can't live without thanking you, because nothing would have been possible if we had just been here and only BSoG were here. So we thank our deity. Everybody has a deity. We thank our deity upstairs or downstairs or west or east, that he made it possible for us to be here today. Then we also express thanks to the Garman Chair and his representatives for chairing this occasion. You are a nice chairman, and we know that you said you bring your people for the October walk, so we'll be expecting them. Then without MSD and Rush, our two major sponsors, we would not have had this place. So MSD and Rush, this has been elevated with all this. It has never happened before. We thank you so much, but we can't go down again. You have to keep going up or leveling it. So next year, if we don't get anybody, we'll ask you to maintain it for us. So that's that. And we know you can also bring in the other big pharma to help. So we thank you so much. We also thank Parliament. I mean, I'm so impressed. Even Nana said it. This is the first. Ni, you see, because I'm tree. Ni ofane wa. Ni said it. This is the first meeting that I've seen the policymakers sit through. Let's give them a hand. Somebody said maybe it's because they are men and all men like breast. So, so maybe we should invite more parliamentarian men. They will come. And then we also should thank Accra City Hotel. We have a 5-year strategic agreement with them where they decided to host us for every program in 5 years. So we will launch our October here. The first Friday in October, we will do it here. And they gave us a very good discount. So 5 years will be with them. And then we also thank all sponsors. We had also had minor sponsors. When I say minor, they gave money. Enough money, but not compared to the rest. We also thank all of them, all the sponsors for this. And then the event planner, you can see the whole place has been, think nicely. I've never seen such a big poster before. So we thank them, and we also thank her crew. So she brought all this, and then she also brought her crew to make this possible. We are streaming Facebook and everywhere live. And then the LOC, the local organizing committee, who managed to put this up together here. All the survivors, all the invited guests, everybody, all those who I want to thank, I'm thanking you now. Everybody, we thank you all. And we hope that tomorrow we will see you all here again. Because tomorrow we will also continue and we will stick to time. So thank you very much. They say when tomorrow, when the cock crows tomorrow, this is BSoG thanking everybody.
Thank you. Thank you, Dr. Nyafo. One last announcement. The name tags, let's kindly do well to leave it at a registration desk. Oh, okay, fine. Okay, then that's fine. For tomorrow, that's fine. And then the online, our people online, so as not to leave you, we are very grateful once again for your presence, and we look forward to your participation tomorrow. On this note, thank you so much. And then we are taking the pictures right in this room because the background is so nice. We need to make good use of the money. We were talking about financing, so we will rearrange the podium, so to speak, and then we take the pictures here. So media team, if you can kindly assist us with the rearrangements. Media team, can you kindly assist the photography team? If you can help us quickly. So our photographers are set. I think we'll ask our honorable chairman and his retinue to kindly do us the honors of sitting. And our honorable members from parliament who are also around. Executives of BSoG, current and past. First, we'll take the current who will join us. Then we have the past. There will be a full group photograph, so let's not be in a hurry to leave. Yeah, so we'll have, let's take some first photograph, then we have the executive, current executives join them. Great. So after this, we'll have all current executives join. After this. So on your mark, photographers, we are ready. Are we good to go? One more. Okay, great. Okay. Madam, please, aside the official photographers, let's try and minimize so that we don't impede their field of. Okay, let's have the current executives join. Yes, and then the council members, current executives and council members of Breast Society of Ghana. Let's kindly join. Prof Clerk, please join them for us. Please. Yes, Prof. Vena Van der Poy, then, okay, former council members present. Dr. Nadoko, please join them as well for us. All former council members present, kindly join them for us. Two of our sponsors, major sponsors, are already seated. Afterwards, we'll have all other members from the sponsorship groups, whether Roche, whether MSD, whether Pfizer, whether Pharma Symbiosis, you can join. Photographer, are we okay? Good. Let's have all the representatives join. Roche, Pharma Symbiosis. No, because we want to take the group pictures so that. So we have all sponsors. If you are part of whether Roche, MSD, Deng Pharma, Pathologists Without Borders, Sonotech, Pfizer, if you are a representative of Asase, we want to see you all here. Great. All survivors should get ready to join. All survivors should get ready. Photographer, are we good? Okay. Let's take this one and then all survivors will join afterwards and everyone else would join for the group photo. Okay, survivors, please join. All survivors. Don't be seated. All survivors, please join. Yes. Great. Photo, please help us organize the people nicely. So current executives, you can resume your seat. So we just have only the survivors. I see we have a number of them. So current executives, if you can kindly resume your seats. Current and past executive council members, please resume your seats. Great. So only survivors. Please, I see we are congregated. Let's try and populate the place nicely. Please populate the place nicely. There's a lot of space on the far right. Please, can you go? Yes. Those who are down to earth, let's try to come forward so that we are not impeded. Okay. Okay. Great. So, photo on your mark. So if there are any other special guests still around, after this we would like to take the group photo and then we have the special guest and we are done. So the next one is for the special invited guests. That's all parliamentarians. The representative for Bank of Ghana present. Please join us on the high table. The Queen Mothers kindly join. Queen Mothers, please join us. All special invited guests from Parliament, from Bank of Ghana, our Queen Mothers, let's kindly join. Okay. Yeah, so good. Great. So anyone who has not taken any of the pictures so far, Breast Society of Ghana members. So and anyone who have seen about 3 people from the back who have not been upstairs so far. So any member of the Breast Society present, join. I see a lot of pharmacists who are managing breast cancer. Well, kindly join. The last picture will be all of us. All of us. All of us. I think that will be a panorama. Yes, good. All of us, all of us. Let's spread across nicely. Let's spread across nicely. Okay. So maybe as many as can come. As many, I think be able to, and so we can probably do it in batches. So as many as can join. As many as can join. Come again. Okay. So as many as can join. I see a lot of women in pink. Please join. As many as will want to join.
And please see me for your lunch coupon. I'll be outside there. Lunch coupon, see me for it.
As many who can join, please do so for us. Thank you so much. Kindly see Dr. Nyafo outside for your lunch coupons. Thank you.